This is Dr. Brian Durie. I'm very pleased to welcome you. Thank you for joining this webinar today, this IMF patient and family webinar. I'm very pleased to be joined for today's webinar by Mary Steinbach from the University Cancer Center in Utah, Rafat Abonour from the University of Indiana, and by Ajai Chari from UCSF in San Francisco. So please welcome to our guest speakers for today. We would not be able to go ahead without the support of all of our many sponsors. Let me read these sponsors. AbbVie, Amgen, Binding Site, Bristol Myers Squibb, Genentech, GSK, Janssen Oncology, Karyopharm, Pfizer, Regeneron, Sanofi, and Takeda Oncology. The good news is that all of these sponsors do have products that are valuable for myeloma patients. And so it's actually great that we do have this number of committed sponsors. The agenda for today with the times listed for the Eastern time zone, I'm starting right now with, I'm starting right now at 5:30 Eastern, which is 2:30 Pacific time. And then I will go ahead with the opening presentation, which is Myeloma 101. There'll be a short Q&A, and then we will hear from Mary, who will talk about taking the reins of your myeloma care. Again, there will be Q&A and a short break. And then we will go into the second session with Frontline Therapy presented by Rafat Abonour from Indiana University, and Ajai Chari from UCSF. So I can't get the slides to go back. Oh, there we go. There will be a Q&A session and obviously closing remarks. So for this first 101 presentation, I've taken feedback to heart. I think that there is an important need just for everyone to be on the same page in terms of what is myeloma, how do we track it, what are the important expectations in 2023 for outcomes related to managing myeloma. And so stick with me as I go through some of the basics, some of which you may know, some of which you actually may not know so clearly. So what is myeloma? Well, multiple myeloma is a cancer of the bone marrow, myeloma cells. So the normal cell that is linked to this is a plasma cell. So there are plasma cells that make antibodies. The malignant plasma cells are called myeloma cells, and they also make antibodies. And since it's a cancer, it's one type of myeloma cell, and it's tracked using a single type of protein, which is a monoclonal protein, which is called an M protein, or a monoclonal protein, or a spike protein. As the myeloma cells, which you can see on the left here, the cells with the big purple nucleus in the middle of the cells, those are the myeloma cells scattered among the other cells. As they increase in number, they create what we call the crab features. They crowd out the normal bone marrow cells and create anemia, which is the A, and then they can cause some of the issues which I'll touch on in a moment. In the big picture, the most important thing to know is that myeloma is, in 2023, a very treatable kind of disease with current therapies. The CRAB clinical features, well, what are those? Those are CRAB, increase in the blood calcium, and that occurs because as the myeloma increases in the bone marrow, it can release calcium from the surrounding bone into the bloodstream, and this can cause problems for the patient in terms of affecting mental function and kidney function. Renal disease can occur for a variety of reasons. There can be damage to the kidneys because of the level of the myeloma protein, also because of calcium, also because of infection, which myeloma patients are predisposed to. Anemia occurs because of the buildup of the myeloma in the bone marrow, and then bone disease because the myeloma, as it grows, can encroach on the surrounding bone. And a variety of things can be experienced by the patient related to the emergence of these features, which can include tiredness, fatigue, sometimes fever, other kinds of things that a patient can experience. The myeloma protein, the monoclonal protein, which is coming from the myeloma cells as they build up in the bone marrow, we use that to track the disease. And so when we're talking about starting treatment, we're very, very interested in the level of the monoclonal protein in the blood, the M spike. And so in this picture here, this shows an electrophoresis, protein electrophoresis. So a sample of serum is taken to the lab and is subjected to electrophoresis, and it's called an SPEP, S-P-E-P, and then in the case of myeloma, an M spike shows up, which is coming from the myeloma cells, which are in the bone marrow. So the protein is coming out of the bone marrow into the bloodstream, and we detect it in the blood. The amount of the M spike reflects, as you might imagine, the amount of the myeloma in the bone marrow, and is different than what is typically found in that position on the electrophoresis, which is called a polyclonal hump, which is coming from normal plasma cells. And so this M spike is very, very important for diagnosis and to monitor the impact of treatment. The type of the protein is also important, and this is determined by a separate test called immunofixation. And you can see here two very dark purple blue lines indicating a reaction in the immunofixation gel, in this case for IgA and lambda. So we have what's called a heavy chain and a light chain. In this case, it was A and the light chain is lambda. You can see across the bottom of the other possibilities are IgG for the heavy chain and K, which is kappa for the light chain. And so we use this at the beginning, at the start of the diagnosis, to tell us what type of protein. And the abbreviation for immunofixation is IFE. So we talk about SPEP and IFE, and this is for initial diagnosis as a basis for monitoring. We also look to the bones. Myeloma damages the surrounding bones, and often, I don't know what happened there, but often this is picked up in screening X-rays, although we don't recommend just simple X-rays for monitoring myeloma bone disease anymore. But on routine X-rays, it does show up as dark spots in the bone, which you can see here in the skull bone and also in the right arm of this particular patient. You see these dark spots indicate patches, what we call focal lesions. Focal lesions, where is a spot of the myeloma which is in the bone marrow and then impacting the surrounding bone. We will normally these days be using other kinds of scanning. If there's pain or a suspicion of problems, we'll often use an MRI scan, in this case, an MRI scan of the spine. And in the vertebra of the spine, it will show up as these dark spots. These arrows are indicating dark spots in the vertebra, in the bone. And in one case, in the middle of the screen, there's a vertebra which is damaged and has actually collapsed and creating what's called a wedge shape as the vertebra has collapsed at the front. And this causes the spine to curve forward. And this is a characteristic feature of myeloma. We also, and this is very, very helpful to screen for the presence of myeloma cells, will do a PET CT scan. And this is an example of a PET CT scan where a small amount of radioactive sugar has been injected, and where the myeloma is active, it shows up as dark spots in the middle slide and as these bright yellow spots in the arm around the elbow of this patient. And so we have all of these different scanning possibilities. Routinely, rather than X-rays, we prefer to use whole body CT scanning to pick up lesions in the bone. PET-C scanning is additionally helpful because it shows exactly where the myeloma is active and taking up sugar as part of the growth process. So the baseline investigations that you should all have had and which will be used for further follow-up are the screening panel, which is that SPEP to see if there's a protein spike, the immunofixation to see what type of protein do you have, and then FLC, which is serum free light chains, to see if extra free light chains are being produced, which indicate the activity of the myeloma. We are interested in the amount of the myeloma protein. We're interested in if you have myeloma in the bone marrow and how much there is. FBC is a full blood count to see if you have anemia or problems with the white count or platelet count. We also want to check on the calcium, the kidney status, and then, as I've shown you, the status of the bones. There are other tests that we do to indicate what could be the expected outlook, the expectation, or what we call the prognosis. And this is indicated by these tests here. The level of the beta-2 microglobulin and the albumin can be used to calculate what we call the ISS stage. As the myeloma progresses, the beta-2 microglobulin goes up and the albumin goes down. And so a high beta-2 and a low albumin, this indicates a more advanced stage of the disease. Elevation in the LDH indicates a more active myeloma, and we're especially interested in chromosome testing, which is done on the bone marrow cells. This has to be done on a fresh bone marrow sample, and we are looking for the presence of chromosomes which indicate there could be more than expected problems with the myeloma. And I've indicated some of the common ones there: 414, 17p, 1q. These are the numbers of the chromosomes that can be affected. When they are affected, this indicates that we know that the first remission that a patient might have would be shorter than expected, maybe lasting less than a year versus probably 4 to 5 years for a more normal person. So we're particularly anxious to see the FISH testing to assess what's there. However, the big news is that myeloma is definitely very much treatable these days. Over 90% of patients respond to current therapies. The average remission is 4 years, despite the fact that some patients with these high-risk features may have that shorter remission. The average overall survival has now improved in the last decade, out beyond 5 years, more into the 7 to 10 year range. And some patients will live out to over 15 to 20 years even. And so the expectations for myeloma therapy are much better these days versus what they have been in years past. And the new therapies are constantly improving the outlook. Now, to understand all of this as well as possible, and maybe to get the best guidance towards the treatment options that you're going to be hearing about, frontline and relapse, it can be very helpful to consult with an expert. At the time of diagnosis, it is good to do it early. And there can be virtual consults, which became very popular during the COVID pandemic, and that can certainly be explored. This is important because it sets the path for the future, but it is important to realize that this is something that can be used to guide your local doctor. You don't need to be always going to that expert. The information can be given to your local doctor and proceed from there until any issues or questions emerge. We do have on the IMF website the kinds of questions that would be good to ask when you have a consultation. Beyond just knowing that you have myeloma, it's important to look carefully at the test results. So in the bone marrow, we're interested in the percentage of the myeloma cells. Is it 20%? Is it 30%? Is it 70%? This indicates to us the amount of the disease and is also a baseline for the future. If you have 80% myeloma and then with treatment it drops to 10%, this is a very excellent indicator of the benefit of the treatment. Likewise, we are interested not just in whether you have lesions or focal disease in the bones, but how many do you have and where are they located? If they're located in an arm, like in this example here, this is the arm of someone with lots of black spots that you can see. This can make that arm very fragile and susceptible to even breaking your arm. And so we need to know, where are the spots? How many are there? Is there a risk of bone fracture that we should be aware of? And more detailed testing can help us even further. That bone marrow FISH test result that I showed you, a picture of it is shown on the left of this slide here, where the chromosomes from the myeloma, these are myeloma cell chromosomes. These are not your body chromosomes. These are the chromosomes from the myeloma itself, which are abnormal. And the colored spots can show if the chromosomes have moved around. And so if two colors come together, like a red and a yellow, they shouldn't be together, or a red and a green. A red and a green can indicate that they've translocated or moved, so that you have what's called 11-14 translocation, and you can determine that by looking at these dots if they've come together when they should not. By looking at the detailed images in PET and MRI, you can get a very clear picture of the extent of the disease. And in the PET scanning, I've shown some examples with arrows where the myeloma can even be outside of the bone, where you can see some spots which are in the bone and the vertebra, but in some cases outside of the bone, which we call extramedullary myeloma. And so, having gone through all of that, understanding the details in your case, what we're going to be talking about during the seminar today is what would be your initial therapy if you're eligible to have a transplant, and we'll be talking about whether that's the case. If you're not eligible for transplant, what treatment would we recommend? And then consolidated therapy, follow-on therapy, and then maintenance. What does that look like? And then, of course, supportive care along the way. If your blood calcium is elevated, if you're having bone problems, these need to be managed in addition, and we'll talk about that. This is helpful just to get a sense of the treatments that are available, and we'll be talking about this extensively today. In old times, we had just at the bottom old types of chemotherapy. But this changed dramatically around the year 2000 with the introduction of all of these different drugs, which are listed over under the rescue column. So all of the different new therapies are tested in relapse, in rescue fashion, where thalidomide, bortezomib, lenalidomide, carfilzomib, ixazomib, pomalidomide, all these drugs which we now use early in the disease, started off as relapse therapies, are the mainstays of therapy that we'll be hearing more about from Rafat. What we'll hear more about from Ajai Chari is the fact that there has been amazing success with immunotherapies, and just to give you a snapshot, these therapies, which are currently standard of therapies, bortezomib, lenalidomide, carfilzomib, pomalidomide, you can see on the left, the blue bars, as single agents, these give a response rate of around 30%. The new immune therapies over to the right, CAR T-cell therapies and bispecific antibodies, which you're going to be hearing about extensively, those produce response rates which are double or even triple that. Ide-cel and cilta-cel are two types of CAR T-cell therapy you'll be hearing about, and teclistamab is a bispecific antibody that will be discussed in detail. And so just to have an idea that all of these are coming into play now, and these are very, very exciting times where these new therapies have just been FDA approved under 2022 into 2023. Belantamab, Ide-cel, cilta-cel, teclistamab, those were all recently approved, along with a couple more that Dr. Chari will talk about, elrantamab and talquetamab, the top brown arrows on the bottom. These have also been approved, and so a very, very active time for the introduction of these new drugs. Okay. So just to set the stage for Rafat, the basis for treatment right now does come from a SWOG study where we've determined that the triple therapy of VRD using bortezomib, lenalidomide, and dex was better than a doublet, 2 medicines. So 3 medicines, a triplet was better than a doublet, and sorry, I'm trying to get this to forward. There we go. And this indicated in the SWOG trial that there was an average length of first remission with the 3-drug combination of 41 months, with an overall survival with 55% of the patients alive at 7 years. And so using a triplet of these novel therapies was a big, big improvement over the previous chemotherapy that we had used for many years. And so Dr. Abonour is going to be talking about what has happened since then in terms of enhancing that, using doublets. What is the impact of transplant? All these different follow-on questions. What patients will be looking to do is to track their disease. Initially, there is a strong likelihood with combinations that we use that there will be a deep first response, possibly down to a level that we call MRD undetected, where even with sensitive testing that Dr. Abonour will talk about more, there may be no evidence of disease in the bone marrow, and this can lead to a much later relapse if you follow that purple line all the way across the bottom. However, for the majority of patients, there will be a tendency for relapse after 4, 5, 6 years, and we try to detect that as soon as possible to achieve the best second response that we can. And Dr. Chari will talk about that, where even in that second line setting, data would indicate the benefit from triplets versus doublets. So we've moved forward a lot in the way that we approach the myeloma landscape. We use triplets when we can. Autologous stem cell transplant can be considered, and we'll talk about that. And we use the supportive care along the way, particularly related to bone disease. And so the big picture right now, treatment strategies 2023 moving into 2024. Triplets or quadruplets, which we'll discuss, can be used in frontline maintenance based upon the risk factors, if they're present or not. The idea that we would want to treat decisively if there's evidence of relapse, again, using triplets if the status of the patients allow. And then we're very excited that we would have the option to consider using some of these exciting new immune therapies possibly earlier in the disease course, if that is possible. So this is the big picture that we will be looking through as we discuss for the rest of the afternoon session. We have a whole range of publications from the IMF that cover many of these different topics, the handbook, the concise review, and you can go through the website to find answers to a lot of different questions. But I'll stop there for our initial Q&A period. So thank you for your attention. And so
Dr. Durie, we could start with question number 2.
Okay, so question number 2, what is the recommended schedule for how often to get certain lab tests such as beta-2, folate, B12, D3, 24-hour urine? Is there a chart with such guidelines? Yeah, we do have guidelines for a lot of that stuff. But actually, maybe I can ask one of my colleagues. Obviously, as I said, beta-2 microglobulin, we use that for initial staging. Folate, B12, and D3 are sort of ancillary tests. 24-hour urine we use to chart the protein in the urine. So maybe Rafat, do you have a flow sheet that you use to track these different things? Some that would be baseline and then some for follow-up?
Yeah, I mean, specifically for this question, the beta-2 microglobulin is really useful just at the diagnosis to make stage the patients. But I don't use it for follow-up. Nobody should use it for follow-up. I think it's not, it does not give you any information. The 24-hour urine collection is probably important at diagnosis to check and see if you're losing a lot of protein in the urine and what type of protein. We used to use the 24 hours more frequently to check the amount of myeloma when it's only secreted in the urine. But that's luckily been replaced by the free light chain assay.
Right.
Nobody really likes to have, a jug of urine in the refrigerator every month or 3. So we use it, less frequently. We use it maybe on clinical trial to document remission, but I don't use the 24 hours for follow-up unless it's really clinically indicated. It's very important that, when we treat patients that we understand also that are they, getting enough nutrition? Do they have B12 or folate deficiency? They always have to try to explain the anemia. When somebody is anemic, is it really related to the myeloma, or is it related to iron deficiency, B12 deficiency, folate? So checking those is very important. And, vitamin D3, there's a lot of data to suggest that it's, number one, it's very useful for bone formation. So obviously, if you're vitamin D deficient, you need that, especially in myeloma patients. 70% of the patient have either osteopenia or bone disease. So I think making sure that your vitamin D3 level is adequate is very important. Some data suggests it's very important for the immune system. So I would probably check the vitamin D3 at least once a year to make sure the patient is getting enough and exposed to the sun adequately.
You would replace it up to a normal range if it was low. Yeah, absolutely. So that's great, Rafat. I was thinking, Becky, maybe we would follow on with number 4 since we're looking at early disease. Does that seem good? Lab interpretation. I showed the spike of the myeloma protein in what's called the gamma region, which is over to the right. But it can also be a little bit over to the left, which is called the beta region. And the myeloma protein can be in that part of the SPEP. Typically, if that's the case, it tells us that the myeloma protein is probably an IgA type of protein versus an IgG type. But be that as it may, wherever it's located, that is the one that we'll follow. Occasionally there can be a couple of spikes, but we correlate the biggest one and the one that's changing with the active myeloma. There is something called the total protein, which is the total of all the proteins, which includes the albumin, the alpha, beta, gamma globulin. Also, there can be some confusion. If you have an IgG myeloma, the total IgG can be different than that because there is normal IgG. And so the total IgG could be higher and different than the level of the M protein or the myeloma IgG. And so that's why it's so important to monitor the myeloma using the SPEP test to follow the level of the monoclonal protein. And so actually a very, very important point. So
Dr. Durie, you touched on the risk stratification indicators. It looks like question 5 is asking for more information on that.
Right. So maybe this could help us with this. I mean, I didn't list all of the risk criteria, but in general, it does vary based upon the exact combination and the number of the different risk factors. Basically, the key way that I look at risk is what I call functional high risk, which is looking at patients who have relapse from their therapy within the first year. And I think that is a helpful way to look at it versus looking at some combination of the chromosomes, because we can have certain combinations which we call high risk, and then ultra high risk if we have a combination of more than one, well, like the IQ plus the 17p, and if you have sophisticated testing where you have double loss of 17p or p53. And so the main thing is to have some awareness that there might be a need to jump in earlier with alternate or new therapy. Unfortunately, we don't have definitive primary therapy for high-risk patients right now, which we'll talk about. So I don't know if Rafat or Ajai, you want to jump in on that in terms of high-risk factors.
Yes, sure. First, thanks for the opportunity to be here. It's always exciting and interesting to hear what patients are thinking about. I think when we think about risk, the high risk to me means whose outcomes are currently not as good as we would like them to be, right? And so that there's two ways of looking at that. One is before you start treatment, and the second is after you start treatment. So the before you start treatment is the crystal ball thing, right? And so the crystal ball would be frail elderly patients, and these are patient factors, frail elderly, and those with renal failure, who you can't get the renal failure reversed. Then there's disease characteristics, such as the ISS stage 3, the high-risk disease by genetics, which you outlined, and then also extramedullary disease, which is myeloma coming out of the marrow.
Right.
And so then the third, those are just a crystal ball, but as you alluded to, what's more important than the crystal ball is what actually happens, right? And whatever risk you might be, the question is, how do you actually do once you start therapy? And so you could be somebody whose crystal ball said you were low risk, but if you relapsed early, doesn't matter anymore. You're now high risk. And conversely, if you had high risk disease, but you've had effective therapy, that's not only the key in high risk is not only getting them to remission, but keeping them in remission, right? So in myeloma, I think high risk and standard risk will respond. One of the big differentiators is the durability of the response. So I think the good news, which maybe underlying that question, is we're doing better and better. And I think in the last segment, we'll be talking about immunotherapies, because by the time people are getting to these current immunotherapy studies, half the patients are high risk. And guess what? These therapies are working even for those patients. And so, of course, we want to move these up early. And there's a lot of excitement about that. But I think risk is also dependent on treatment, right? So what we used to call high risk 20 years ago, deletion 13 is no longer high risk. So I wouldn't, I think in oncology, we're a little reluctant to overdo crystal ball because we keep changing and we're not God. We don't know the results. We do the best we can and we give the patient the information, but the reality is what happens is really the most important.
Yeah, very, very helpful, Ajai. And obviously it's exciting, which we'll talk about later, is that we do have some new therapies and combinations which are working well in patients with high risk, like extramedullary disease and the like. And so we do have some promising data for that high risk group of patients. Maybe I can quickly touch on just a few of these questions just to answer them. Is the percentage of myeloma different than the percentage of plasma cells? It's basically the same. Many times the report will say plasma cells when it really means myeloma cells. And so in the case of a myeloma patient, then it's basically the same. When we're looking for very, very deep levels of response, stringent complete remission, we will do special testing with kappa and lambda light chains to see, yeah, that was question 13, yeah, to see if the cells are myeloma cells with the monoclonal pattern versus regular plasma cells. So there are regular plasma cells and the myeloma cells, but to distinguish those, you need to use special testing, which is kappa and lambda, which we do to document a stringent complete remission. Myeloma is not really a hereditary cancer. I mean, there is a low tendency for myeloma patients to have other members with the disease. We're actually doing a big study in Iceland where we're looking to see if there are genetic factors that predispose to myeloma, and there will be new information coming out for that. But as of now, maybe 5 to 7% of patients with myeloma will have another close relative with myeloma, but usually that's not a strong genetic factor that we can determine. Focal or lytic lesions, do they look different on MRI or PET scan? Yeah, so we do distinguish between focal lesions and diffuse lesions. So I showed you pictures of bright spots, which are called focal lesions. I also showed you pictures where basically the vertebra was wiped out and dark on the MRI, and that is basically diffuse involvement of the bone in that particular case, which shows up on MRI, also on a PET scan. So we do pay attention to whether it is diffuse or focal. Yeah. We're going to be talking about immunotherapy. We're going to talk about the therapy in more detail in a moment.
Dr. Durie, maybe a really important one that's very important to myeloma patients these days, number 9.
Number 9. Oh yeah, number 9 is a good one. Yeah. So how far are we away from being able to detect myeloma and the degree of cancer burden from blood versus needing a bone marrow? And actually, this is pretty exciting in that we do have blood testing available now, which will be presented actually in a coordinated way at our upcoming ASH meeting in December. But it's been presented before, where using the same testing that is used in the bone marrow, next generation flow, using a flow cytometry test, you can use that exact same test in the blood using a method developed by Dr. Bruno Paiva in Salamanca and Pamplona, Spain, to look at whether or not there are myeloma cells in the blood. And so this will allow us with proper validation to move away from routine bone marrow, where we only need to do a bone marrow in certain circumstances if we have evidence or concern about progression. And this progression can also be picked up in a more sensitive way by one other test, which is mass spectrometry. So there is one other blood test which is coming into approval and commercial use, where it's a much more sensitive test to pick up the level of myeloma in the blood. And so using this sensitive NGF test to detect myeloma cells and mass spectrometry to pick up low levels of protein in the blood, it will be possible to shift away from always having to go to the bone marrow to assess the disease status. So this is going to be great news for patients. Okay. I think that is probably good for now. We're running slightly ahead, but some of the others I think we should pick up as we go through the further presentations that relate to treatment. Okay, so so without further ado, I'd like to move forward to our next presenter, and I'm very, very pleased to welcome Dr. Mary Steinbach from the Huntsman Cancer Institute at the University of Utah. And she's a member of the Nurse Leadership Board, and this year the board has been very much focused on the symbolism of the horse. And so what Mary is going to do is explain to you about taking the reins of your myeloma care. So please welcome Mary.
Thank you, Dr. Durie. It's an honor and a pleasure to be here. And you're right, we do have an equine team to help us understand the myeloma journey for you guys. Horses really, they have a spiritual and majestic power and a lot of symbolism. So hopefully you can appreciate it. We'll start by going over some basics of treatment. We'll get to a lot more detail through some other presentations tonight, but I want to talk to you about the basics of starting treatment, side effects to be aware of, side effects of myeloma itself to be aware of. And then we'll speak to getting to know your care team and really getting into stride with myeloma and your diagnosis. And how to be successful in visits with your care team, and then going the distance, which speaks to living well with myeloma, right? Our goal as providers is to have you guys living your best life in spite of and despite of your multiple myeloma. So beginning with treatment goals, essentially and very broadly speaking, the goal of treating your myeloma is to get rapid and effective disease control so that we can limit the damage done to your body. As Dr. Durie explained, that CREB criteria speaks to organ damage from the disease itself. And once it's identified, we want to really rapidly get disease control. And then we want that disease control to last and become what we speak of as a durable response. And we know that doing this helps improve your overall survival. It minimizes side effects related to your myeloma and hopefully allows you a good quality of life. And along this way, we're always talking about support for you as the patient, for your caregivers, but we want you to have limited or minimal side effects from your treatment and from the disease. And so discussing your goals of treatment, the goals of life, your social situation, it's really an important part of making decisions with your care team. Here, we pretty succinctly have the majority of our currently FDA-approved myeloma treatments, and across the top is the type of medications by class, and then on the left side are the indications. So frontline treatment, maintenance, eligible, we're able to give to patients at relapse, and then even some that are pending FDA approval. This slide has a lot on it. I think an important take home is that we have a lot of different treatment options. And we do know by class and mechanism of action that there tend to be certain side effects associated with certain medications. And I think we're nearing a time where all of this doesn't fit on one slide. So we'll see where that goes in the future, but that's pretty exciting. I will more specifically speak to the newer immunotherapy and cellular therapies that we have, just because I know people are asking and it's important to know what's out there. Right now it's approved for fourth line and after most of these medications, but we have some bispecific antibodies and CAR T-cell therapies that carry specific side effects that are worth speaking to. So CAR T is a new treatment approach. It has a novel mechanism of action that we will hear more about later, but I think the important thing to point out here is CAR T is complicated. There's a lot of logistics involved, patient planning from the healthcare system side. And so it is best to be referred early or consider CAR T early. The system infrastructure that's required for a healthcare system to deliver CAR T safely to patients requires certain types of monitoring. And for this reason, CAR T is currently accessible mostly in urban areas and in larger academic or larger healthcare systems. So because of this, it's important for patients all over the country to be aware of it and ask for early referral so that we can get planning for all these steps we see here. And what do I mean by early referral? So currently, as I mentioned, these are approved at 4 lines or more, including 3 of the drug classes. So patients have to have had an immunomodulator, proteasome inhibitor, and an anti-CD38 antibody. I think patients are best referred when you're currently stable, right? So you're on a treatment line, and if you or your provider wonders if the next line might be CAR T, then it's time to refer to that CAR T center. The CAR T centers need to do prior authorization with insurance, which can take weeks. You need to be fit and well to be eligible for this. And often, well, there are washout periods for treatment. So when your disease is stable or fairly well controlled, that's the best time to be able to go through these washout periods for pre-apheresis, which is collection of your T cells, and then before the lymphodepleting therapy. Patients are currently admitted for their CAR T, and it can depend on institution or area of the country that you're in, and then also what product you're getting. That'll determine kind of the length of admission. But the reason for admission is because of the adverse effects that are very well known to us at this point and very manageable, but you do need to be hospitalized for the monitoring. Patients need to have a caregiver for about a month at most centers. And then importantly, there's no driving for 8 weeks. And this can vary from center to center, but this recommendation exists because of the potential for some late onset toxicities that can occur with CAR T therapy. It is a one and done treatment, and that's kind of a catchy phrase that we like to speak to, but I think it's important to know that it is a one-time therapy, but there can be ongoing effects that need to be monitored. And a lot of it gets done in this initial phase when you're at the CAR T center, but then it's really important for CAR T centers and community providers to have good communication about you guys as patients for monitoring over the long term. So another interesting and newer class of drugs that target BCMA, and also now we have a bispecific antibody that targets GPRC5D, which is so a non-BCMA bispecific. These work similar to the CAR T in that they activate T cells, and depending on what the target is, they bring your T cell and your myeloma cell together. As I mentioned, this is available after 4 lines of treatment as well. We're seen really, really nice responses, and I know we'll have more information later on this. Depending on the bispecific, there are certain side effects to be aware of. So the BCMA targets are associated with infectious complications. All bispecifics have the potential for CRS and neurotoxicity similar to the CAR T. So again, these are can be given in the community, but there have to be certain monitoring standards in place. And this is an off-the-shelf treatment, which makes it more readily available. So a little less logistical planning on behalf of you as the patient and your healthcare team. And as I mentioned, these do not have to be given at a CAR T center. Okay, so I have alluded to this CRS, which is cytokine release syndrome. It's a common adverse event that can occur with a CAR T or a bispecific therapy. The classic presentation of it is fever. Patients can often also feel fatigued. You can end up being confused, have nausea, vomiting, kind of flu-like symptoms, low blood pressure. And in the case of CAR T monitoring, this is when we want patients in the hospital for this type of monitoring. Bispecifics have a little more flexibility because the occurrence of CRS in general is less frequently. But at this point in time, this is pretty predictable based on products. And so as healthcare teams taking care of patients who are at risk for CRS, we know kind of when it might happen, and patients understand how to identify it with some education, and then we can treat it and really minimize it. And the same is true for neurotoxicity, which is an effect that can occur either with or without CRS when patients are receiving CAR T or bispecific antibodies. This can include confusion, headache, severe forms of it can have seizure, facial nerve palsy, difficulty walking, difficulty word finding. So this is the reason why driving is limited for patients post-CAR T, but the proper assessment and then treatment of neurotoxicity is important too. So again, just a part of the education when you're going to receive these treatments. Infection has always been an important thing to be aware of as a myeloma patient, and with the CAR T and bispecifics, it is even more so. But the tips and the ways to manage it and try to prevent it have not changed over time, right? So good personal hygiene goes a very long way. Washing hands, avoiding crowds, avoiding actively sick people. We do have growth factors that we can give to patients who, if you have a low white blood cell count and you're at risk for infection, obviously, we have antibiotics and antifungals that can treat infections, and then immunizations after transplant and after CAR T, again, are important to help prevent some of those diseases. COVID-19 is still around, and the best way to prevent it is to wash your hands, avoid being exposed to the virus, right? But that is not always possible. Wearing a mask in large crowds when you either all the time or when you are most susceptible is still recommended. We definitely recommend the COVID vaccine, the influenza vaccine this time of year. And I think one thing we all did recognize, right, is that wearing masks does make a difference. It helps prevent, it helps protect you as the patient and keeps you from catching things. And then next up is just another schema of common side effects. So these are more of our classic myeloma side effects from treatment, right? So the risk for DVT, keeping your bones healthy, keeping your kidneys healthy, preventing infections, peripheral neuropathy, and GI symptoms. And we'll spend the next few slides going over some of these a little more specifically, but these have always been a part of myeloma care and are important to understand. So some of the medications we may treat with put you at risk for developing blood clots. Bone health, as Dr. Durie mentioned, patients are at risk for, if you have bone lesions, you're at risk for fracture, and many multiple myeloma patients have osteoporosis at baseline. So it's important to understand your bone risk and then treat with bisphosphonate or other bone strengthening drugs, calcium and vitamin D, and then treating those fractures or lesions if necessary. Multiple myeloma can adversely affect the kidneys. So a lot of patients either present with kidney failure or unfortunately can develop kidney failure at times of progression. So we always want to think about keeping kidneys healthy, which includes hydration, avoiding medications that can be toxic to the kidneys. I spoke to infection prevention already. Peripheral neuropathy is a tough one, right? So this is a subjective, it can be a very subjective symptom, the discomfort that comes from it. Some of our treatments cause peripheral neuropathy. And so speaking with your healthcare team and letting them know what you're feeling and how it's progressing depending on your treatment is very important. GI symptoms can be constipation, diarrhea, nausea. Again, these can be very patient specific or unique. And so it's important to speak to your healthcare team about the symptoms you may be experiencing, and then we can help sort out what to do about it. So I've spoken a little bit about side effects from the medications we use to treat your myeloma, but also multiple myeloma has symptoms just related to the disease itself, right? There was a large meta-analysis a number of years ago that analyzed what patients' reported symptoms are and what the impact was on quality of life. And so it's important for us as your healthcare providers to understand this. Fatigue is number one symptom reported for multiple myeloma. Constipation is a GI side effect that can occur. Spoken to the neuropathy, pain, obviously, from your bone lesions. So these are all physical symptoms that are important to be aware of. But we never want to underestimate the psychological or the financial burden of having multiple myeloma. And so depression and anxiety can set in with any type of cancer diagnosis or really any alteration to your life. It's important to really get good sleep. And sleep disturbances come with not only some of the medications, but also, right, the knowledge of having cancer and dealing with that. Sometimes patients feel like they're just not thinking adequately or their brain has slowed down. And this can be from medications, but also just from some of the psychological symptoms as well. And then the financial burden of multiple myeloma, this is big, right? We know that patients do better when they're on continuous treatment, and treatment is expensive. Often it may take you away from work. It may take your caregivers away from their work. And so if you are feeling the strain or of some financial toxicity, it's important to talk to your healthcare team. There are a lot of organizations who are patient advocacy organizations like the IMF and the Leukemia Lymphoma Society that have certain grants and funding mechanisms for patients. So it's important to ask. Just a few slides we'll get specifically into. I mean, we can't have a myeloma supportive care talk without talking about steroids. I think we more recently with the newer therapies can use less and less steroids, which is, I know, appreciated. But still, in your initial treatment line, steroids are very important. And depending then on what type of therapy you're on, the steroids can be a big component of it. There are side effects associated with steroids. Speak to your team about what you're experiencing. It can be different for everybody, but some common known occurrences is irritability or mood swings, blurry vision, might put you at risk for more infections depending on that dosing and the frequency. They can increase your blood pressure, can certainly cause you to have trouble sleeping, feel hungry, which can lead to weight gain, and it can affect your blood sugar levels. So there are tricks about how to manage these side effects and kind of limit them where we can. So please speak to your healthcare team about your steroid side effects as well. I mentioned a little bit about the GI symptoms. I always speak to patients like, I like to get a baseline of what someone's GI function is, right? Because then you can know how to assess going from there. Someone who tends to be constipated even prior to any therapy might have a worsening of constipation. They might actually welcome some loose stool or diarrhea from the medications they're taking. So it's important to first speak to kind of what your baseline is, and then we can direct you on what we think the side effects might be from the medications, and then help with some supportive care, such as anti-diarrhea medications on a regular schedule if we know it's associated with one of the drugs you're taking. And then constipation can be relieved by increasing fiber. And diarrhea can also be resolved with some forms of fiber. So it's important to talk to us about this. And then pain prevention and pain management. So pain, a lot of multiple myeloma patients live chronically with pain from their bone disease or damage done to the bone. And so it's important to treat your pain. And there are many ways to treat pain nowadays. We, of course, have our classic opioids and pain management medications, but there's a lot of alternative therapies out there now too. At Huntsman here, we work very closely with a supportive oncology service who helps with long-term pain management for patients. And so it's worthwhile to ask about alternatives for pain management other than opioids. Movement can help pain. Radiation can certainly help pain when it's related to a focal lesion. Peripheral neuropathy, again, it can be numbness, tingling. It can be this thick feeling on the bottom of your feet. It can be all of a sudden you're having trouble buttoning your shirt. I mentioned it can come from some of the medications that we use, but also some patients have peripheral neuropathy at baseline. And so it's important to understand what that is. We know that massage can help, acupuncture can help, and then some supplemental vitamins do work for some people. The pain management side of peripheral neuropathy can be challenging, but we do have alternatives to narcotics and opioids that work well for a lot of people. So again, just ask your care team about that. So I mentioned that fatigue is the most common reported symptom, and let's not underestimate it, right? You can be fatigued for a lot of reasons: the medications, the disease process, the fact that you're not sleeping because of the steroids. And so one of the concepts we know really well in oncology is that cancer-related fatigue is best managed by activity. And that can be really hard to conceptualize and kind of overcome when you're feeling exhausted and dragging. I like to speak to patients about how it really doesn't take much, right? So kind of no matter what your baseline activity level was, just getting up and walking for 2 or 3 minutes can really make a difference to kind of help stimulate your brain and help stimulate your muscles and get over this fatigue hump. And I recognize it is not as easy as it sounds. It's quite challenging, but I do know from experience of patients that it does help. Rest and relaxation, and really trying to limit stressors where you can is going to be very important for you feeling as good as you can too. So having a healthy sleep cycle, decreasing anxiety where you can, and we can use sleep aids for patients if you need it. And again, just speaking to your team about why this might be occurring, and then we can figure out together about what the best ways are to manage it for you and help you feel as rested and relaxed as possible most days. A little bit more on the financial burden. So you guys know this from firsthand experience that it comes from the medications, co-payments, sometimes travel to and from the facility for your care, prescription costs, loss of income from not being able to work, or your caregiver not being able to work. And as I mentioned, we have here a few websites that commonly can have assistance programs for patients. Finding your gait. So here we are getting into kind of the last final portions of how to live well with myeloma. So here's you, right, in the center of your care team. We have our most favorite myeloma specialist, Dr. Durie, there, and then all the other providers and healthcare professionals who are here and work for you to try to make, the decisions you want to have and the way you want to be treated and live your life make sense with your myeloma therapy. So please always ask questions, write down questions when you think of them at home, and bring them to your appointments. The IMF has a number of very, very, very good, very easy to read sources of information for patients. Knowledge is power. We recognize that there's going to be time periods where you want to know more and time periods where you don't want to know more, right? Sometimes it's just very overwhelming and it's not the right time to learn everything about a certain medication that you're going to take. But just know that the information is out there, and when you are ready for it, the IMF at myeloma.org is a great location to go for it. And then last, but certainly not least, we'll speak to going the distance, right? So how to live as healthy as you can with your myeloma. Prevention of other chronic diseases or other types of diseases is going to be very important in this. Often patients ask the question of like, what can I do to, tolerate this better? Or what can I do to make the next line of therapy better? And my answer is always like, as healthy of a diet as consistently as possible, adequate activity and exercise as often as you can, get good sleep, and do things you enjoy, right? So find what that is that fulfills you and try to access that as often as you can. Because a patient who stays healthy otherwise then will be eligible for further treatments down the line as their disease changes and you need other treatments. Yoga and Pilates and Tai Chi are really low impact ways to stay active and flexible. It has been shown to improve sleep, improve your mood. Journaling can go a really long way with just noting kind of how you feel on a daily basis. Sometimes I ask patients to keep a diary or journal their symptom patterns so that we can better understand it in relationship to the treatment they're on. And I say all this, but I also want you guys to recognize that there are going to be days where this is very achievable and days where it's not achievable. It's important to listen to yourself, right? Don't overdo it. Don't force yourself to do something just because you know that it's better in the long run. It's not right to do every single day. You got to listen to your body and your mind. And that is it for me in our equine journey through myeloma care.
Well, thank you so much, Mary, for that really careful discussion of the issues that face myeloma patients and in so many different ways. So we do have a little bit of time for Q&A. And so, Becky, you want to scroll us through any sequencing on these questions that have been coming in?
Absolutely. We do have a couple of questions, Mary, about CAR T therapies. So if we want to start with number 36, that would be great.
36, actually, I'm not seeing, hold on a second. Let's see if I can see 36. Can you read 36? Let's see. I'm trying to scroll up.
Pretty much, can you please define CRS? Pretty much as a patient trying to learn more, it's hard with the acronyms to keep everything straight.
All right.
I'm happy to take this one, and probably one of you guys could
maybe AJ can add some things on that.
Yeah,
Go
I
ahead.
did skim over that acronym. So CRS stands for cytokine release syndrome. This is an occurrence that happens based on the T cell activation from either your CAR T therapy or your bispecific antibody. And it's actually like a little bit of a good thing, because then when these T cells are activated, they are more able to recognize the myeloma and do what they're supposed to do. So cytokine release syndrome happens early after CAR T treatment and those bispecifics, and how it manifests in the patient is often fever. That's really the first sign. We can also see an increase in heart rate, a drop in blood pressure, and a need for oxygen. And we have a very well-defined grading system for cytokine release syndrome, and then approaches for treatment to help dampen that cytokine release and keep the patient safe.
Miko?
And if anyone else wants to chime in on the rest of that, go for it.
I think you did a great job. The only thing I would just for patient perspective, this is one of the main reasons that these immunotherapies are super exciting, but they require training on the part of the providers and the institutions. And that's why a lot of these have some language that patients should be monitored closely. And so the key is should, right? So bispecific should be admitted for 48 hours after some doses. CAR T should be monitored. But I think we're really early in the learning curve for all of these. I'm reminded of, 20, 30 years ago when our first monoclonal antibodies like daratumumab, but myeloma was relatively late to the game, but we were just learning how to give those drugs. And there was a lot of concern about fevers and blood pressure and oxygen. And then now no one bats an eye at those. But because these are new therapies, we're all learning how to do it. But I think we need to balance convenience, but safety. And I think with continued iterations, we'll get better at that.
All right, that's good. So what do you suggest next, Becky? I was not able to scroll down for a minute here, but did you pick up any others that you think we should focus on here?
Absolutely. I think number 37, and it may be, better answered by the panel with what you're seeing coming down the pipe.
Number 37. So number 37 is, why do some treatments only happen after 4 lines of therapy? This has been a frustrating thing about some of the relapse studies, where to get into a relapse study, you have to have had a certain amount of previous therapy, and this is the way that these are structured. And so, Ajai, you want to comment on that? I know that it's particularly frustrating if you want to get someone into a CAR T or a bispecific trial, and for the benefit of the patient as well.
Yeah, I think it's of course really exciting, and these results we're getting, we want to, the question's understandable, but if we step back a second and think about how drugs are approved, first they're tested in cell lines, and then maybe it works, then you go to animal models, and maybe it works there, then you get to patients. But at this point, we don't know anything about, not only forget about how well does it work, we don't know anything about the safety. And above all, in our oath in medicine is do no harm. And so from a drug development perspective, all the health authorities and the like the FDA, the EMA, and the regulatory agencies supervising clinical research at an institution like IRB's institutional review boards, the first and foremost goal is to protect patient safety. And so when you don't know anything about a new therapy, you have to assume that it could cause harm, and you start at very low doses, and then you test it in patients who've exhausted all therapies. Because for patients with myeloma who've been newly diagnosed or maybe have one prior therapy, it's not ethical to expose them to risks that we don't know about. And so that's why we do it in these heavily treated patients first. And understanding that people are hoping for a response for themselves, but also trying to contribute to the body of literature for other patients. So it is a volunteerism and societal benefit that people are engaging in. And what's remarkable, because actually there's been studies in these initial phase studies where you're really looking at safety and not efficacy, in spite of the consent form and the physician and nursing education, if you ask patients who enter a clinical trial where we don't know about activity, it's a phase 1 dose escalation study, and you ask them, what is your likelihood of getting a response? What do you think it is? Patients will report very high numbers, and you can understand why. But the reality is most of those drugs don't even work. And so for every drug that makes it to the market, there's plenty that were littered and are left by the wayside that don't work. And so once a drug is proven to be safe and efficacious, then we start doing the confirmatory studies. And then that's in a larger group of patients still with advanced disease. Then we compare it to existing studies in earlier phase. And that's only then that you can give these new therapies. And every drug that we have in myeloma has had to go through this process. Advanced line of therapies, prove that it works in a small group of patients, then do a confirmatory phase 3 study, and then eventually get it approved. And so it takes time, but it's remarkable. I think we were all showing the charts, but Mary showed all the drugs, and so did Dr. Durie, that how much progress has happened in the last 20 years, right? It's remarkable. And in spite of all those barriers that we just covered.
Right, right. So maybe just to emphasize that there have been important side effects with some of these exciting new drugs. The response rates have been incredibly high. However, there have been serious infection complications with the bispecifics, neurologic complications, which are not trivial with CAR T-cell therapies. And so we do need to very carefully balance the potential side effects, which could be serious for a patient with earlier disease versus what seems to be a high likelihood of benefit. That toxicity factor we really need to get a strong handle on as we move therapies into earlier stage patients. Okay, another question. What do you suggest, Becky? I can see a number here now.
Brian, can I just make a comment?
Yeah, Rafat, go ahead, please.
So sorry to interrupt, but it's really very important to know that the needle is moving forward quickly. There are ongoing trial with CAR T cells and bispecific in earlier line of myeloma management. So I think there's a good news. I think that we are studying these drugs early on, and we have to do the trials, and we're doing them now. So I really think we will get a readout in a year or so, and we'll start using them in early line of therapy. So good news, I think, on the horizon for myeloma patient. We don't have to wait forever.
Absolutely, absolutely. Already they're moving into these earlier phases of disease. Yeah. So Becky, I can see a number of questions here. What do you suggest next?
Okay, I'm seeing kind of 3 themes to quality of life for Mary to discuss. The first is nutrition with question 42.
Question 42 is a nutrition question. All right. But fruit and vegetables. Okay.
Yeah, I saw this question and really wanted to answer it. So thank you. So the question is, on the one hand, we are told to be careful with raw vegetables and fruits, yet on the other hand, they are healthy options. What is the opinion on fresh vegetables and fruit? And is watching your white blood cell count and neutrophil count enough? So good nutrition is the most important thing. And there was a point in time where a neutropenic diet or a low microbial diet was the recommendation for patients. And that was like no raw fruit or vegetables. This has shifted, and you can eat raw fruit and vegetables. They need to be cleaned appropriately. And depending on kind of how low your white blood cell count is, that recommendation may change. But I think as a whole, you guys should just know that it's always going to be better to eat whole foods, fresh fruit and vegetables over something that's packaged or heavily preserved. And so just if you are neutropenic at the time, please have someone else wash these and dry them, peel the skin on certain fruits and vegetables, like have someone else do it. But yes, please eat them still.
Right. Thank you. So I'm looking at one question that maybe be helpful for us to touch on is question 45. It's regarding steroid therapy. And the question is, what low dose is still effective? Obviously, we frequently start with 40 milligrams, sometimes 20 milligrams in an elderly, frail patient. But what is kind of the sweet spot in terms of a dosage that maybe patients can take on a regular basis? So Rafat, is there a dose that you will reduce to where you feel comfortable the patient could continue on that for a while?
Well, I mean, the question, yeah, I mean, yeah, it's a great question. Does the patient really need to continue on steroid? I mean,
Right.
data suggests that long-term steroid actually not beneficial in patients with multiple myeloma. If you look at the first trial and others, basically, I mean, continuation of steroids forever is not the best thing. And obviously, it's really very important, probably when you first diagnose in the first month or two, to help control the disease, to control the symptoms. But after a while, I mean, I think the less, the better. And you just, you know, nobody really knows what the right dose. I mean, you just have to work with your patient,
Yep.
listen to,
Right.
and try to use as less as possible. But I think, you know, probably we will get rid of it sooner than later.
Yeah.
I could just add that I think I always like to ask patients how they're tolerating steroids. And usually what's very classic is that the patient's like, fine. And it's the caregiver that's absolutely shaking their head. They know when the patient's on the dex day and irritable, cranky, not sleeping. But I just want to say that I think we can't have a blanket statement about steroids. For example, the IMID category of drugs as a single agent, Revlimid or pomalidomide, only work in about 10% of patients, and it's only with dex that you get the 30% response rate. So for IMIDs, there is this combination effect, and same thing with selinexor, where selinexor by itself does not work as well as with dexamethasone. That said, with a lot of the immune therapies, like with monoclonal antibodies like DARA or with the bispecifics, it's not intended to be given forever. It's really just at the beginning to prevent either allergic reactions or the CRS that we talked about, cytokine release syndrome. So I think the dex use is really patient specific and drug specific. And the other comment I would make is for some patients where and you have to also think about how well the patients responded. If you're in a complete remission, I think it's the first drug we all drop out, right? Because
Yep.
you don't need dex if you're already maximally debulked. But if there's still residual disease, sometimes we give it. And one thing I do in some patients who don't tolerate dex is I'll switch it to prednisone because it has a shorter half-life, and some of our older patients seem to tolerate it better. So if you're trying to walk that tightrope, but it definitely is the least favorite drug. And I think there's a hashtag on Twitter and now X, down with dex.
Right. So certainly you should always discuss and make sure that your spouse or partner has a chance to discuss what's happening with the dex and can the dose be reduced, or as Rafat's been emphasizing, you know, and you as well, Ajai, maybe you can get off of the dex if you've had an excellent remission for an ongoing period. Yeah. Okay, we've got time for maybe one or two more questions. Becky?
Yeah, Dr. Durie, I'd like to focus on another quality of life conversation, peripheral neuropathy. And we have two questions, 38 and 44, that have to do with that.
Okay, 38. For peripheral neuropathy, how much information is available on scrambler therapy, okay, which I think is therapy at the Cleveland Clinic, as I recall. And then what were you saying, 44?
Yeah.
Can early onset neuropathy be reversed at a minimum, prevented from getting worse? Or vitamin B's important for therapy? So who would like to start maybe with the scrambler therapy? Mary, do you know about the scrambler therapy? That it's yeah.
Yeah, I can speak to it a little bit. Thank you. So scrambler therapy is electrodes, multiple electrodes put on the spot of where neuropathy is. So maybe on your feet. It is not, doesn't get paid for very well. So it can be an expensive thing to do. And it is still under clinical trial investigation. There are people who respond to it. And so I think when patients have like severe peripheral neuropathy that really challenges their daily life, and they've tried a lot of other mechanisms, this I would certainly recommend and refer them for scrambler therapy if it's possible for them to receive it. I think it's depending on kind of where you live, it may not be easy to access this type of therapy.
Right.
And as I mentioned, it might come at a high cost, but it can be effective for people.
Right. And then early onset, what can we do really? I mean, obviously the big thing that we always emphasize is that if you're developing neuropathy, is to reduce Velcade or get off Velcade or whatever's causing the neuropathy. But if you have early neuropathy, is there a secret recipe to try to help?
I think the main thing, as you alluded to, is kind of prevention and monitoring early, because it is dose related. So for example, Velcade, probably the most notorious drug, if you give it at full dose twice a week, that's going to be much worse than once a week, and also worse than lower doses. So evaluating it and reporting early. Thalidomide was another drug that we don't use very much that caused neuropathy. And then I think the other things that I sometimes do is vitamin B12 is a level that you can check that can cause neuropathy. So if it's low, it's an easy fix and can cause fatigue. We've also had some patients that had carnitine levels that were low, and that can have, we've replaced that, and that's been helpful. IVIG, which is actually used for immune boosting treatment, is actually a drug that is also used for certain types of neuropathy that sometimes we use. And so I think the mainstay, though, is really reporting it early. And one other thing, I guess, in some patients who have existing neuropathy, it seems to worsen when they get leg swelling. So trying to minimize that skin stretching that actually causes it to flare is another thing that might be helpful.
Right. There is a combination of supplements that's used at the Dana-Farber, which Paul Richardson in particular usually emphasizes. We do have that listing on our website, so if you want to check that out, that combination they do use, as I say, at Dana-Farber, something to think about. Rafat, no special techniques in Indiana.
Well, the best treatment for neuropathy is not to get it. So obviously,
yeah, absolutely. We really work hard now, and so really that is a collaboration. So early neuropathy, let your doctor know, and maybe your treatment can be adjusted to prevent it. I think that's the key first step. Okay, we've got time for maybe one more question, yeah.
Possibly another side effect question, number 49.
Okay. All right. 49 is high-risk myeloma and being treated with DARA-RD, the Maya protocol. I've developed severe edema starting in the feet and progressed to the thighs and abdomen. My goodness. Any suggestions for the treatment of the edema? Well, who would like to take that? I think that my first thought is that I'm not sure the edema is related to the treatment, but anyway.
Well, I mean, obviously, this is a very good point. I mean, I think the physician should be monitoring, number one, the kidney function and monitoring the albumin and also the amount of steroids. So, and also make sure that the patient doesn't have thyroid dysfunction, if they have hypothyroidism. So really, I mean, I think, it's easy to write chemo order, but it's not easy to manage patient if you don't listen to them and pay attention. So really, are you leaking protein? Your normal albumin is too low. That's right. Why, having that problem. Are you getting a lot of steroid? Is your thyroid function working well? Did you have any heart issue? Did they do an echocardiogram to check your heart? So this is not, trivial things. I mean, this is very important symptoms that this patient having a progressive edema and require a very attentive physician to try to address that.
Absolutely. I mean, this requires detailed testing. It sounds like what we call nephrotic syndrome, which is a kind of kidney problem, frankly, and that needs to be worked up with kidney testing, urine testing, and the like. But as you say, it could also be a heart issue. And so I would strongly recommend some follow-up testing with the doctor for kidneys and heart, and just to check out what's going on. Steroids can cause some edema, but nothing like this.
One other thing just to keep in mind, I think I completely agree with everything you both said, but it ties into the neuropathy. We probably don't appreciate the presence of concurrent amyloid enough, right? So about 10% of patients with myeloma have concurrent amyloid, and I find amyloid patients, and for the patients, the difference is that I described the proteins, in particular the light chains in myeloma, get produced, circulate, and get urinated out. But in amyloid patients, those light chains are sticky. and can deposit into different organs and cause organ disruption. So it can cause heart problems, causing fluid retention, can cause kidney problems, causing fluid retention, and can cause nerve problems, causing neuropathy. So I think if somebody has symptoms that are not typical and are out of proportion to what you would expect, then it's important to screen for amyloid. The treatments are the same in some sense, but I think amyloid patients are more fragile, and you have to kind of attenuate the doses to make it more tolerable. So that would be another important thing to just rule out.
Yeah, that is a very good tip. Ask the doctor to check and make sure that there isn't amyloid. But I would just emphasize that this is a significant issue that needs to be investigated, evaluated, and treated with some degree of urgency, I would say. So check it out with your doctor as soon as you can. Yeah. Okay, I think that that's all that we can cover before the break. So thanks so much to Mary for introducing this topic of supportive care and giving us the reins for the horse to move forward. So welcome back, everyone. Hope that this has been a helpful, worthwhile seminar so far. Very pleased to be able to introduce Dr. Rafat Abonour from the University of Indiana. He is a multiple professor there. He's the Harry and Edith Gladstein Professor of Cancer Research, but also a professor of medicine, pathology, and laboratory medicine, Rafat. And in addition, the director of myeloma and related diseases. So really very much in charge in Melvin and Brand Simon Cancer Center. So very, very pleased, Rafat, all joking aside, that you can be with us and give us the benefit of your expertise and long experience in the management of upfront myeloma. So please welcome Dr. Abonour.
Thank you, Brian. It's very kind of you to introduce me and include me on this amazing panel to talk about multiple myeloma. It's seeing the questions is amazing how much myeloma patients know about the disease and still eager to know more about it. So I'm going to talk today about upfront therapy for a patient with multiple myeloma. So obviously the treatment goals are two. One is that you presented with bony pain, anemia, kidney failure, high calcium. So we have to control your symptoms. So we need to get rid of the pain and other disease-related symptoms, preserve your organ functions, make sure your kidneys and heart and working well, and preserve your performance status and improve it and improve your quality of life. And obviously the other goal of treatment is to control the disease. So you really need to get rid of myeloma, because as soon as you get rid of myeloma, the sooner the patients start feeling better. Obviously, you need to give a treatment with minimal side effect. And the goal is that if you get diagnosed with multiple myeloma, it doesn't become a death sentence, but become a disease that you can live with for a long time and quality of life. And I'm going to go through some of the treatments and the evolution of the treatment that can provide that. So first of all, I mean, I think, you heard from Dr. Durie about, how we measure response. And I think the response matter, just getting rid of half of the myeloma, which we used to call PR or partial remission, doesn't really give you a lasting response. But getting rid of myeloma into a complete remission, where you don't see a myeloma protein in the blood or the urine, the immunofixation is negative, and the bone marrow doesn't have any myeloma cells left in it, also can produce a larger duration of response and survival, but it doesn't last. So people start looking at, can we go deeper? Can we get rid of more myeloma? So we start including stringent complete remission, where the light chain ratio and levels are normal. But that wasn't enough. You can see from the curve is that, you're getting a deeper response, it's taking you longer to relapse, but we're not getting there. So I think that's what led to the evolution of something called minimal residual disease. Let's do some sensitive assay to look inside the bone marrow and see how we can determine what is the number of myeloma cells left behind in the bone marrow that we couldn't really see on just a simple bone marrow analysis. And so MRD became very important. And if you have, very little myeloma left behind. It'll take you longer to relapse and you may live longer. And if you have undetectable MRD, you may stay in remission for a very long time and maybe you are cured. So that's why MRD sort of became very interesting prognostic factor and maybe a way to manage patients. So how do we measure MRD? There's two ways to do it. It's one by what we call the flow cytometry or Euroflow, developed in Europe. And basically you take the bone marrow and you isolate all the cells that are, we call them nucleated cells, and then you analyze them and use different what we call markers on the surface of myeloma to identify the myeloma cells. And there's like 10 color, we call it flow cytometry. And it's, you know, really very good. I mean, we can analyze up to 10 million cells in the bone marrow, and then we can determine how many of those were myeloma cells. And we can, you know, find 10, 20, 100. So they give you different sensitivity. And it's accepted that, you know, the sensitivity of flow is about 1 in 100,000. But if you look more using a more sophisticated technique based on the myeloma specific sequences, we call them DNA sequencing, using next generation sequencing, you can get a maybe higher sensitivity. You can find one single myeloma cells in 1 million. Both of them are very good and very useful in monitoring the patients, and they've been used in clinical trial to sort of test the quality of the response and the duration of response. And Dr. Munshi did a very important study where he looked at what is the impact of having MRD negative results after induction treatment. And if you, you know, these are what we call survival curve. One of them is surviving without the disease or burden of the disease. And one of them is overall survival, you know, how many patients were alive. And these are, you know, these Kaplan-Meier showing that if you achieve MRD negative bone marrow, you tend to stay in remission longer and you tend to have a better survival than the patients who have a residual myeloma detected by MRD testing. And they looked at, you know, whether it's applicable to both the high-risk patient and the standard risk patients. And it looks like it's also benefit some of the high-risk patients. If they achieve MRD negative, they tend to survive better without myeloma and survive longer period. So basically, that is generating sort of, you know, information that, you know, maybe achieving an MRD negative that is sustained, maybe it's an opportunity so to start de-escalating. You know, one of the questions in the chat was, you know, my doctor said, I don't care about your MRD. I'm just going to keep treating you with lenalidomide because, you know, you're going to relapse. Well, I mean, maybe some of the data, you know, that we evolving suggest if you achieve the complete remission that is MRD negative and you sustain that, maybe it's an opportunity to use less treatment and, you know, save the patient's side effect and cost. So MRD is evolving. It's not, you know, sort of standard of care, but it's very useful prognostic tools and maybe can guide sometimes the therapy of the patient, really by carefully discussing the implication of that test on their therapy. So you saw this slide earlier from Dr. Brian Durie. This is obviously really exciting. I mean, I know this is 20 years since we had bortezomib approved in 2003. And look what we have now in 20 years. It's an amazing, amazing time in the management of multiple myeloma. Because, you know, as you saw earlier, for example, when we had bortezomib only with steroid, you know, the response rate was 30% and patient lived a couple of years. Now that we're getting response rate of, you know, in relapse patients in the 60, 70, and maybe higher percent. So it's exciting. And what I'm going to show you is that, you know, single drugs may not work well and combination work better. Maybe that will change once we start using the novel therapy earlier in the course of the disease. So this is what your doctor tend to see, something called the NCCN guidelines. So basically they tell you the preferred regimen, the useful in certain circumstances, and then they say it's category 1. Definitely great, use it. We have a lot of evidence to support it. Maybe not so if it was a grade 2B or less. So this is good for your patients for your physicians. Having option is great, but how to manage that is not easy. It's like, you're going to a cheesecake factory and trying to pick a dish. It's a lot of options, but it's great to have options because, what you can do is you can tailor it to your patients. So what is the highlight of upfront therapy? Combination therapy continue to prove superiority in providing long remission. The patient is in good place because we have options. The most effective regimen still today is lenalidomide, bortezomib, and dexamethasone, or the RVD regimen. Adding daratumumab to an IMiD like lenalidomide in a frail patient is a great option. And there are more to come, so let's talk about it. So you saw this study, and Dr. Durie didn't really sort of brag about it, but he was the PI on it. He's the principal investigator of the SWOG study. And the first thing was, in 2005 and in 2006, we were very excited to have Revlimid, and we started using Revlimid Dex as an induction treatment. But the question that Dr. Brian Durie and colleagues asked, can we improve on the outcome by adding bortezomib to Revlimid? So it was a very simple study, but it was very meaningful because what it showed is that the patient can live longer without relapse or disease-related burden, and they can live longer when they receive a triplet, 3-drug regimen versus 2-drug regimen. So I think that became sort of the standard of care that we have been using for a long time now. So, but the question is that, do you always need bortezomib? I mean, can you use a different triplet? And this is a study called the MAIA study. That was an international study that looked at daratumumab, the monoclonal antibody to CD38, with Revlimid Dex versus Revlimid Index. And the question is that, can we improve what we call progression-free survival, basically living longer without the disease relapsing, without disease-related burden or complications. And so these are the, patients who are enrolled, a large number of patients, 737 patients, 360 some patients on each arm. Your typical sort of myeloma patient, the median age was 73. A large number of patients were older than 65, since this was labeled as, transplant ineligible patients. So if you look at the result, this is a table of the results. So just go overall response rate, is much better. There are more patients responding when you use the 3-drug regimen of daratumumab, lenalidomide, dexamethasone compared to lenalidomide, dexamethasone. More complete remission, 51 versus 30%. And more importantly, there are more MRD negative patients, 32% versus 11%. And sustained MRD was also higher. Lasting more than 12 months was seen in 18.8% versus 4%. So really, this study was remarkable for producing great eradication of myeloma, large number of patients achieving MRD negative that is lasting. So it became an exciting regimen for patients who choose not to or not eligible for transplant, and a lot of people are using it with acceptable side effect profile. So obviously, every time you have to use a combination therapy, you need to make sure that it's not adding toxicity. The major toxicity here that was noted is more patients get what we call neutropenia, where they drop their neutrophil counts. These are the cells that sort of help us fight infection. They are first line of defense. So that translates to increasing the risk of infection. So you have more neutropenia, you're going to get more pneumonia. So I highlighted those in red. This medicine was initially used, the daratumumab, as an infusion, so there were more infusion-related reaction. Now we're using daratumumab as a injection underneath the skin, which is associated with less side effect in terms of reaction. So it's a reasonable regimen, but obviously you have to monitor the patient carefully when you treat them with this combination to make sure they don't get any recurrent infection, use prophylaxis, and other things to prevent infection. All right. So the other question is, can you improve use the triplet in patients who get transplant? And this is a very interesting study from France that looked at doing an induction with RVD for 3 cycles, and some group get transplant and and other group did not get transplant. And after transplant, the patients will get couple more cycle of RVD, but the patients in the no transplant arm will get total 8 cycles, and then they get maintenance lenalidomide for 12 months. And what it looks like it is that, you know, initially, if you look at time without relapse, the median progression-free survival, it was 50 months versus 36 months. So it looks good, but the 8 years overall survival was similar in both groups, 62%. So it suggests that maybe a later relapse is that can be managed by transplant will lead to similar outcomes. So it's provocative study, but at least prove that 3-drug regimen does work with transplant, does produce lasting responses and improve the survival. I mean, this is 8 years overall survival, 62%. So clearly significant improvement. And it looks like, you know, the standard risk do much better than the high risk with the transplant. So, and you know, you can talk about these studies for hours, try to find sort of, you know, reason to like one arm over the other, but at least it suggests that, you know, it's a good idea to use a triplet. It's a good idea to collect stem cells and store them, and you can do the transplant up front or later. Okay, that's all I'm going to say about that. But what's interesting also in this study that there are more MRD negativity in the transplant arm, and this is just showing you the patient who achieved MRD negative, whether it was with transplant or without transplant, tend to do better than the patients who get MRD positive result after the initial treatment. So again, I think getting to MRD negative is a good thing. You can get more patient into MRD negative if you use transplant up front. That's based on that study. Okay. So I guess that, you know, some people will argue that this actually, the French study is very important because they only use maintenance for 1 year. So I guess the question is that if you achieve MRD negative and you use maintenance for only 1 year and you stop, that's a lot of time without therapy. But if you stayed on therapy, do you get more patients into MRD negative? Are they going to live longer? But it's an opportunity, I think, to investigate the impact of achieving MRD negative on the management of patients with multiple myeloma. So I think that's why it was a very important study. Okay, well, we said 3 drugs are better than 2, so can we do better with 4 drugs compared to 3 drugs? So this is a trial done in the US called the Griffin trial. It was a, you know, phase 2 study that compared Revlimid Velcade Dex to Revlimid Velcade Dex with daratumumab. And this was a transplant study. So everybody get an induction 4 cycles, then they get a transplant, then they get consolidation for a couple more cycles, and then they get maintenance. And there are 2 types of maintenance were offered to these patients. They randomized to either receive lenalidomide, Revlimid alone, or Revlimid with daratumumab. And it was a large study, and it was your typical patient populations, 60%, a median age 60, you know, high risk was seen in 15% of the patients. So what happened here? Well, you know, this PFS, again, living without relapse, without disease-related complications, was superior with 3 year and 4 years follow-up in this study. And you can see the graph on top, the blue is the Darzalex, Revlimid, Velcade, dexamethasone. 4 drugs produce a superior result in terms of progression-free survival. They have not reached, enough data to, at this time of publication to talk about overall survival, but it looks very promising. The other thing happened is that the sustained MRD negative was higher in the daratumumab arm than in the Revlimid arm. So it was very encouraging because number one is that you're getting deeper responses in a larger number of patients, you living longer without relapse. So that was, it's very encouraging. And actually in the US now, the 4-drug regimen is becoming sort of pretty the standard of care. So this is a summary of upfront therapy with stem cell transplant, different studies published. So we have the IMF that we talked about it early. Then we have the sort of the American version of that called the Determination Trial. Then you have I did not present this trial, the Forte, which is instead of Velcade is carfilzomib, Kyprolis. And all of them suggest that, you're getting an excellent overall response rate, you're getting an excellent, very good partial response, and you're getting a better progression-free survival in some studies, and maybe in some study improvement in overall survival. So again, I think the field has moved from 3-drug regimens to a 4-drug regimen. So let me talk to you about a very interesting study and provocative, and I think the first author on this is Luciano Costa, and I start calling him Maestro Luciano because the trial is called the Master Trial. And the Master Trial was really trying to say, okay, can we use sustained MRD to guide our therapy? We're going to do an induction treatment with daratumumab, carfilzomib, lenalidomide, and dexamethasone. But we're going to do it this way. So what he said, okay, we're going to do a 4-cycle of induction treatment. We're going to do a stem cell transplant, and then we're going to measure if you have what we call an MRD sure. And if you do have an MRD sure, we're going to watch you carefully. But if you still MRD positive, we're going to give you consolidation therapy for 4 cycles of the same regimen, Dara, carfilzomib, Revlimid, dexamethasone, and then repeat the bone marrow assessment for MRD sure. And if it's negative, we're going to stop. And if you're still positive, we're going to consolidate you with more 4 cycles. After that, he decided to give up. If you're not MRD negative, you're going to stay on maintenance lenalidomide. So it's very provocative. He's trying to say, if you achieve MRD that is sustained, can we make a decision about not continuing therapy? And so let's see what happened here. So basically what he said is that if you actually do these combinations, you're going to achieve a large number of patients without relapse, and it looks like the overall response rate, look how flat those lines on top. So basically what happened is that he looked at the cytogenetic and he said, okay, if you have 1 high-risk cytogenetic, you're going to do actually as well as patients who have 0 high-risk cytogenetic. But if you have more than 1 high-risk cytogenetic, 2 of them, he labeled them the ultra high risk. So the 1 high-risk cytogenetic didn't matter. You did as good as if you have a standard risk myeloma. But if you have a couple high risk, that's still a problem, need to be addressed. But I think the provocative thing is, look how amazing that progression-free survival. Some people will argue that they doesn't have enough follow-up. It's only about a median of 30 months or so, 2 years of follow-up, so we need more follow-up to see if these results are sustained. Can you really use MRD as a surrogate marker to stop therapy? So follow-up is very important. So hopefully we will see those results as they mature. So this is his conclusion, I think, that, next generation sequencing MRD is feasible in 96% of the patients. Standard risk and one high-risk cytogenetic did fairly well with this approach of 4-drug regimen with transplant, and then make a decision based on MRD negative or not at each step. And, and again, raise the question that you really have to do better for ultra high-risk myeloma. But it was very provocative, and I think it support the use of 4 drugs. Are there more 4-drug regimen? Yes. The German group published on using another monoclonal antibody, isatuximab, with lenalidomide, bortezomib, and dexamethasone in patients who are transplant eligible. This was a randomized study. So what did it show? Basically, this is the randomization. You're getting the 4-drug versus 3-drug stem cell, and then maintenance with Revlimid or the monoclonal antibody isatuximab with Revlimid. So what did they show? Well, they showed that MRD negativity was higher at 50% versus 35%. And so it does translate to statistically achieving higher MRD. So 4-drug regimen give you deeper response. And basically, this is just showing you the response after each part, after the inductions, and you can see there are, seems to be good results there. So was there any excessive toxicity? It doesn't look like it. Again, the neutropenia is higher with any time you use the anti-CD38, so that can translate to increased infection. But otherwise, it looks basically similar. So it is very interesting, and that led to sort of a new study that just looked at this combination, isatuximab, but with carfilzomib, lenalidomide, dexamethasone in the high-risk patient. And this is a paper just published in the Journal of Clinical Oncology. And basically, this is a complicated slide, but basically showed you at the end of consolidation, you're getting more patients into deeper response, more complete remission, more stringent complete remission. Looks like it's lasting, and there are more patients achieving MRD negative. So again, I think in the higher risk patients, to have a regimen that will give you deeper responses and more MRD negative and lasting is an encouraging results and worth pursuing. And this is just showing you more details of the progression-free survival based on different things. I'm not going to spend time on it, but it's good. So here is my summary, I think. Adding CD38 antibody to VRD or KRD is feasible with limited incremental toxicity. Depth of response has improved. That include MRD negativity. MRD will be an even more important measures going forward, I think. And there's a trend to improvement in progression-free survival. This may overcome high-risk feature of some patients, as you saw in the master study. We still have to do work for all the ultra high-risk patients. What about transplant? I mean, I think it's still an important part of the therapy. Most of the trials I showed you included transplant. So we shouldn't be ignoring transplant. We should be discussing it and weigh the risk and benefit of doing it or not doing it and do that. So what I think the future is what Dr. Luciano Costa and colleague in the Master Consortium trying to do is, okay, well, we told you that, maybe consolidation after stem cell transplant is a great thing, but can you do something different? Can you do, instead of, more chemotherapy, can you do T-cell directed therapy? Or should you do just a monoclonal antibody and Revlimid? I really think that's a very encouraging and brave approach, because obviously you're going to hear from my colleague Ajai Chari that these drugs we can give today in fourth-line therapy, and we have a great results, and we managing the toxicity fairly well. Why are we not using them early on to see if we can get a true MRD negative, and maybe we can start curing some patients. So that's my talk. Thank you.
All right. Well, thank you so much, Rafat, for that comprehensive overview of where we stand with frontline therapy. Exciting to move from 3 drugs to 4 drugs, and as you said, integrating the novel therapies, the immune therapies now, to achieve maybe even better results. MRD, a very important endpoint to try to assess benefit. So we do have quite a number of questions that have been coming in. Becky, do you want to help select? We actually don't have a lot of time. We're going to have to do the speed round on the answers here. So do you want to pick a few that we should touch on?
Sure, absolutely. And just briefly before we do that, we have been getting several questions if the slides from tonight would be available. And I just wanted to assure everyone that they are actually going to be available as soon as this is over on the myeloma.org website. They will also be emailed to you. And the replay of this webinar will also be available on the website as well. So no worries there. So we do have a lot of questions about MRD, and obviously that's the main topic here today with a lot of these questions. So I'd say 63, 64, and 66 are good ones to start with.
64 and 66. Okay, well, 64, can you explain the new blood test for MRD? Does IU have this capability? And then 66, MRD to minus 4.5. Okay, consider MRD, it does have to be minus 6. Actually, maybe I can start with this. The MRD, since I touched on that earlier, the MRD test in the blood is really not widely available yet. This is a test that was developed by Bruno Paiva using a special immunomagnetic bead technique to concentrate the myeloma cells so that you could do a very sensitive test in the blood. So that is not currently available outside of Spain, to my knowledge, but it will be. This is something that will become available, especially since the next generation flow is going to be commercially approved very soon by the FDA. And then Rafat, you want to touch on MRD 4 or 5 versus 6? I'll just say that in our response criteria, we have response criteria that we agree among the myeloma experts, the IMWG, where MRD negative down to the minus 5 is acceptable as MRD negative. Obviously, minus 6 is 10 times better. Rafat, do you want to comment on that?
Yeah, I mean, I'm sure my colleague will also comment on that. I mean, the most important thing is really, I mean, it's just testing it once and testing it in the bone marrow in one side may not be very informative, because obviously, I mean, I just saw a patient today and he said, what did that mean? You know, we did the bone marrow on him a month ago and it was MRD negative, not 0 myeloma cells. And now his M protein is 0.5. So obviously what happened is that I hit the side that didn't have any myeloma in it. So it's so important that we not depends on one number. You would really, I mean, on one test, you have to do it maybe twice. And then you have to look at the other things. I mean, have you looked at the PET scan? I mean, does the patient still have active lesions somewhere else that, you know, so I think it's evolving the role of MRD in really managing the patient, is, you know, and just one test doesn't mean anything.
Right. I think that word evolving is probably the best thing for patients to be aware of. I mean, I think that you touched on the one point, which is sustained MRD negative. And so being sustained at 6 months or a year, very, very important. If the MRD negative is sustained for 1 year, for example, this makes a big difference in terms of the length of the potential remission. Just one test, as you said, is just not enough to predict that potentially a high-risk patient might relapse soon, for example. So it relates to the depth, which is -4, -5, -6. With the blood testing, the new blood testing, you can get down to -8, 100 million. And so once you get down to a certain level, it could be that just the depth will be a strong indicator, not just if it's sustained. Okay, another question, Becky, what do you think?
So moving away from MRD, back to more frontline therapy question, number 18.
Number 18, okay, number 18. Okay. Why do some patients receive consolidation pre-maintenance versus going straight to maintenance? All right, well, that's an important question. Yeah, so consolidation is one of the least standardized of the ways that we treat myeloma, I would say. Rafat, do you want to comment on that?
I'll be very brief. I think we use a lot of terminology in myeloma that sometimes don't make any sense. So basically what, probably is, let's call it continuation of therapy. And if you have large volume disease that left behind, you really need to continue the therapy. So whether you call it consolidation or continuation of therapy, doesn't matter. We're trying to get rid of myeloma. So we may not be able to do it with one drug. So that's why we use combination. I think that's maybe the simplest way to explain that.
Right. And so maybe, Ajai, you can touch on this when you talk about immune therapies. I think that one of the really exciting things, which I see in several of the questions, is if you're not in a full remission, if you're not MRD negative, how about introducing some other new therapy, like an immune therapy, to achieve a better response? And it does seem that that will be more feasible, and we're going to be getting a lot of data on that to show benefit of using the new immune therapies earlier. And hopefully we can then kind of standardize this kind of a consolidation of where we would recommend it, because actually stem cell transplant is a type of consolidation. Basically, you're trying to consolidate what you've achieved with that initial frontline therapy. And one question that we'll talk about in a minute is, does it look like some of the immune therapies could potentially even replace the traditional consolidation with stem cell transplant? Okay, I think we could do one more question before we go ahead with Dr. Chari.
Could I just add a quick word about I think just for MRD that patients should remember, because I think, and there's this joke, if you ask 2-3 myeloma doctors, you'll get 4 opinions. But the reason there's so much confusion about the MRD from a health authority's perspective is in clinical trials, we don't test every patient. We test people who we think are in complete remission. Of those who test, there's about a 10% failure rate, either because they didn't get to the lab in time, they didn't get a clone. And then of those who got tested, some may or may not have had radiologic disease. And then the sensitivity may not have been as deep. And then it may not have been as persistent. So we as a community have not done a good enough job of doing the test. I think this conversation would be very different if we had had a blood-based MRD testing that we could have been doing systematically every month on all patients. And so right now, I would just tell patients that MRD positive is not fatal. MRD negative is not a cure. And we need studies because, of course, MRD negative sounds better. It's a good prognostic test. But what we really want to know as a patient is, can you transfer it to a predictive test? And what that means is, can you make treatment decisions based on that? And that's the challenge, is how do we move from predicting that somebody's going to do better or not to actually making a treatment decision based on that? And we need more data, and super excited that your assay that you've pioneered is going to be available. So just wanted to add that one bit. briefly.
Right. This is such an important point. I mean, you could make a case for really not doing MRD testing outside of clinical trials right now because there are so many issues. Was the sample good? Did it get to the lab in time? What kind of method was used? Were there enough samples and enough cells in the sample? All kinds of questions. Was this a good time to do MRD testing? And so until we have that solid data coming out of trials where you can make a decision, the MRD information can be tantalizing, but confusing. So let's go ahead. I think that we can come back to some of these questions and we'll have an open Q&A at the end. And so if we could go ahead now.
Dr. Durie, can I interrupt for just one quick second? Two quick questions that I see that may help people to understand a little bit more with Dr. Chari's presentation, describing the difference between PFS and OS for
Right.
viewers. And another one, what does a 30% response rate mean? Does that mean that 30% of patients have had a response, or that they've had a 30% improvement in their
All right, these are a couple of simple ones. Yeah, I think obviously the difference between PFS and overall survival, very, very important. And so progression-free survival is what those words mean, but basically it's a measure of how long the patient stays in remission. And so this is very, very different than overall survival, because obviously a patient can be in remission with one therapy, then they get another therapy, and then another therapy, and then how long they're surviving with all these different therapies is the overall survival. And so what's come up now in the recent past is to assess the impact of a particular treatment. We use this PFS measure, which is the progression-free survival, or another one, DOR, duration of response, which indicates the benefit with a specific therapy, because the overall survival is influenced not just by that one therapy, but all of the new and exciting therapies which are coming along, which can extend the survival. And so a very, very important difference there. And then the other one was a 30%. What number was that?
A 30% response. Does that mean 30% of patients responded in these studies, or that the patient had a 30% response? I believe it's option one, but I just wanted to clarify that as it was asked.
Right. Yeah. So yeah, we do use those percentages. So the response is reflected by the percentage. And so as Dr. Abonour said, a 50% response, that means that the myeloma has dropped by 50%. So the protein level went from 6 to 3. That would be a 50% drop. If it dropped by 30%, it would drop from 6 to 4. That would be a 30% drop, or a 30% improvement, okay? In general, that doesn't have a strong impact on outcomes. You need to have at least a 50%. And as Rafat was saying, we are really aiming for 75%, 100%, or MRD negative to really strongly impact the benefit for the patients. We also sometimes say that 30% of the patients will have had a particular level of response, like an overall response rate, which would be at the 50% level. So it definitely can get confusing. I hope that's helped.
Thank you, Dr. Durie.
Okay, so I think we should go ahead now with Dr. Chari. I'm very, very pleased that you've taken the time to join us and go through relapse and immune therapies. Dr. Chari has recently moved and is the professor of clinical medicine and the director of the multiple myeloma program at the University of California in San Francisco. And so really welcome to Dr. Chari in California.
Thank you so much. So I think my work is going to be much easier because my colleagues have all done a great job summarizing. But I think to put this talk into context, I just have shown you steroids, conventional chemos, and IMiDs. And I should mention, when I was a fellow here 20 years ago at UCSF, we just were starting thalidomide. And then in the last 20 years, we've added these 4 new categories of drug with multiple drugs within each class. So we have the IMiDs, the proteasome inhibitors, immune therapies, which we're going to talk about here, and then XPO1 inhibitor. And just to, I think my next slide, please. My clicker disappeared there for a sec. Okay. So some of the terminology that we need to keep in mind are the triple class exposure. What does that mean? It means you've had an IMiD, a proteasome inhibitor, and then one of the CD38 antibodies. Next slide. And then we have the T-cell redirection therapies. And that can be divided into the bispecifics versus the CAR-Ts. Bispecifics, and I'll show you some examples of what that looks like. But we have 3 of them that are now approved and commercially available: talquetamab, teclistamab, and elranatamab. And then we have 2 CAR-Ts, ide-cel and cilta-cel, also known as Carvykti is the last one. And I'm just going to see if I can get next slide, please. Okay, so this is the progression-free survival and duration of response for recently approved therapies. So on the left, you can see that these drugs have been super important for patients. Pomalidomide, carfilzomib, Dara, Celi, they all work for about 3 to 4 months in terms of the progression-free survival, which is how long the patient stays in remission. And then the newer therapies are working anywhere from 11 to almost 3 years, 11 months to 3 years. And guess what? This is in patients who've had all those drugs on the left, right? Because the current approval for all of these 5 new therapies is at least 4 lines of therapy or more, and IMiD, PI, and CD38 exposed. So it's really remarkable. One of the things that was one of the hardest things, and I know I've gotten texts from some of my patients in New York who are attending this session, but one of the hardest things about leaving New York and moving to SF was saying goodbye to patients. And some of them, we were reflecting that we had even had hospice conversations, and yet now they're in their deepest and most durable remissions. And it's remarkable, right? Like, and it's a great privilege to be involved in these PIT therapies for patients. Next slide. So my slide, I'll briefly talk about bispecifics, both BCMA and non-BCMA, and not just the single agent, but combinations. And then we'll talk about CAR-Ts, both the initial studies that led to what we call accelerated approval, and also really exciting randomized phase 3s, because you all were asking, why don't these move earlier? And now I can show you data that we actually have for these studies and these interventions in earlier lines of therapy. I think as we keep adding drugs to our arsenal against myeloma, one of the difficult questions is, how do we sequence this all? Because we're so busy getting drugs approved, sequencing is a much more difficult thing. And sometimes we don't study that formally in clinical trials well enough. And then there's the logistics of getting these therapies, and then briefly comparing the two. Next slide. So what is a bispecific? Oh, I think my slide might have worked, but maybe if you could go back one, please. All right, so next slide, I think. Oh, maybe we double clicked. Okay, so first I just wanted to mention, this is, I think, fascinating, that every monoclonal antibody, whether it's Dara, rituximab, IVIG, COVID antibodies, wouldn't be possible without myeloma. In 1984, the Nobel Prize was awarded for taking spleen cells from a mouse, infusing them to myeloma cells from a patient, and then that generated these antibodies. And we now have antibodies for almost every human condition, and it's all due to myeloma. But the first antibody for myeloma wasn't approved till 30 years later in 2015. And so we had the naked antibodies, but now, and then an antibody drug conjugate that was actually briefly on the market and then withdrawn. And next slide. But now we're going to talk about the bispecific antibody. And the targets of these CAR-Ts and bispecifics are shown in the ovals here: BCMA, GPRC5D, and FCRH5. So why am I showing you this slide, which looks like a bunch of gobbledygook numbers and letters? And the main reason I want to show you this slide is the target selection is essential. You need to pick a target for immunotherapy that is specific to myeloma, but not present on every other cell. Because the way we're using these T cells is we're trying to wake up your T cells in your body and having them attack the cancer, which they had not been doing, and that was their job. And so if we don't pick the right target, yeah, you could kill the myeloma, but you could kill other cells too. Now, the targets that we've picked here, these three are overexpressed in the myeloma cell, and you can see at the bottom, this is the myeloma cell. However, some of the side effects have to do with where else are these proteins expressed, and so that's the only reason I'm showing you this slide. Next slide. So here are the T cell and NK cell engaging antibody studies, and there's a lot of them. And so the first list and the category on the table are all BCMA. Most of them are also targeting CD3. CD3 is a protein that's expressed on the T cell. So these are kind of like what I call the double-sided tape, if you will, where one side is binding to the tumor on the myeloma, BCMA, and the other side is binding to the CD3 on the T cell. But there's actually interesting molecules also bringing in the NK cell, which is a different part of the immune system. Then there's two, talquetamab and furintamab, that are targeting GPRC5D, one targeting FcRH5, and actually there's a couple that were studied targeting CD38, which is the same one as Dara and isatuximab, but we haven't heard much about those. And most of these products are being given till they stop working, but there's actually two of those that are in red are actually fixed duration. Next slide. So now we'll do a deeper dive into the BCMA bispecifics because there's two that are approved, teclistamab and elranatamab. Both are given initially weekly, sub-Q, meaning under the skin, and both were initially approved on the basis of these studies where there were 5 lines of therapy and almost all the patients, 80 to 100%, were triple class refractory, meaning they were no longer responding to PIs, IMiDs, and CD38 antibody. And in this heavily treated population, we saw a response rate of over 60%, and the progression-free survival for teclistamab, which is a more mature follow-up, meaning we just have longer data on that, was 11 months, and the duration of response 18 months, which is an amazing outcome for an off-the-shelf product. Elranatamab looks comparable so far. And so the question that some patients may have is, why do we need so many, right? Because now I'm showing you on this table other drugs that are also in the same BCMA space. And I think at a high level, the responses are going to be the same. You can see that row response rate, they're all about 60%. And I think there's not really going to be a big difference between efficacy or safety, which we're going to talk about in a little bit. But I think the main things are going to be convenience and schedule and cost. And so convenience and schedule, you can see at the top, one of them is given every 3 weeks. Some of them are given intravenously. Some are given every 2 weeks. So that's going to be like this convenience and schedule question. Cost is something that, we don't talk about enough, but we need competition, right, to drive down drug prices. And this is great that in myeloma, we're having so much interest in this space, and hopefully that'll drive down the drug cost. Next slide. Next slide, please. And luckily, I don't need to go over this again because Mary did a great job talking about CRS, but basically this is one of the side effects. When you activate your T cells, they can release chemicals that are intended to kill the cancer, but those chemicals or cytokines can cause symptoms such as fever, low blood pressure, low oxygen, which we need to manage. Next slide. So what is the safety of these two products? They work very well, and the CRS is quite common. 60 to 70% of patients have them, but most of them are low grade, meaning people are not getting very low blood pressure, requiring oxygen. They're quite manageable. One of the big concerns about these is the infections. In the most recent data cut, up to 80% of patients that have gotten these types of drugs can get infections, and about half of those are severe infections, meaning requiring hospitalizations, IV antibiotics. And as a result, we're also seeing people unfortunately dying, even though their myeloma is under control, but from these serious infections. The good news is there's something we can do about that, and I'll show you on that next slide. But the other thing that we see from these agents is low blood counts, and particularly the neutrophils, up to 50 to 60%, and can have significantly decreased neutrophils. And a teaser as to what we can do is shown on the bottom row, that hypogamma, which means that when we use these BCMA targeting therapies, yes, we kill the myeloma, but we also kill some of the normal immune cells and the normal plasma cells. And so these patients end up with very low protective antibodies or low IgG levels. Next slide. And here you can see from our recent publication that got a lot of interest on former Twitter, now X, which is if you give a BCMA bispecific on the left, and presuming that they're staying on it because they're responding, every patient's IgG level will essentially go to 0. And that's because this these products are not able to distinguish between good and bad plasma cells adequately. So as a result, these patients, as I mentioned, are getting infections. The good news on the right is that if you replace the good antibodies with what's called IVIG or intravenous immunoglobulin, and that's a monthly 3 to 4 hour infusion by IV. There are some ways to give it sub-Q, but you can decrease on the left bar. You can see that severe infections, when we look at all types, is reduced by 80%. So the observation is without IVIG and with is in blue. And if you look at bacterial infections specifically that are severe, you're reducing it by 90%. So this is huge, hugely important, and we've started implementing IVIG for BCMA bispecifics pretty much right off the bat. Next. And so the strategies to reduce infections on these BCMA bispecifics, because it's a tragedy to have somebody's myeloma be in remission and yet they have complications. So one, vaccinate prior to these therapies, because once you start these therapies, you can see the antibody levels go down. So you may not respond as well to vaccines, in particular, those seasonal vaccines like COVID and flu and now RSV. We want to try to vaccinate before we start these. I mentioned the IVIG. We want to continue antibiotic prevention for things like shingles and PJP, which is a rare opportunistic infection, meaning something that's pretty common in the environment that healthy people don't get, but it can cause respiratory issues in immunocompromised patients. And then some of the other questions we're asking is, can we go to a less frequent schedule? Can we do lower doses? Can we stop therapy and give people a break so that we can then retreat later? And to echo what Mary said, good hand hygiene is really important to prevent these infections. Next slide. Now, there are some other ways of giving bispecifics. Talquetamab is also now approved, and this targets GPRC5D. Frontline is a similar GPRC targeting agent. And then finally on the right, you see cevostamab, which targets yet another protein known as FcRH5. All of these are uniquely overexpressed on myeloma. These are typically given, the TAL and Frontline are given subcutaneously, Cevo is given IV. The schedule can be every 2 weeks or every 3 weeks. And again, remarkable that in an off-the-shelf product in heavily treated patients, we're seeing responses. You can see ORR is 60 to 75%, which is really incredible. The duration of remission, most recently updated actually with talquetamab at 0.8 is actually 14 months, which is quite impressive. And then the other ones are less mature. And so based on these data, this was approved. An interesting column in the middle called the either dose is in 50 patients who actually had prior CAR-Ts or prior bispecifics, because that's the new unmet need. What if you get a bispecific or CAR-T targeting BCMA and then your myeloma comes back? We show here that the response rate is 63%. And again, really even more so in CAR-T than prior bispecific. So it's good to have more options. Next slide. Next slide. What are the side effects of this? Here we're seeing the infections is more modest. And I should mention that talquetamab, like teclistamab, both were accrued during COVID era. And there were quite a few teclistamab complications with COVID, but we don't see that with talquetamab. And part of that is because when you give talquetamab, you can actually mount COVID antibody responses, as we've shown in the laboratory. So it's a different target. And so people often say all bispecifics cause infections and immune compromise, and I don't think that's personally true. It's really product specific and target specific. The neutropenia rate, which is the low white count, is not as severe here. Unfortunately, the labeling is off. There have been no deaths actually on talquetamab due to side effects. And again, so very favorable infection profile. But here you do get some other target, what we call on-target off-tumor effects, which means GPRC is expressed on other areas. And so where is it expressed? It's expressed on the skin. So you see 50 to 60% of patients can have skin toxicity, nail changes in about half the patients, the nails get a little fragile. And maybe the most tough one to deal with is the loss of taste or dysgeusia in about 50%. Not completely sure why that occurs. Perhaps this is expressed on taste glands. But the good news is that these are responsible for, these are actually related to the dose of the drug. And so you can skip the drug and reduce the dose, and they seem to really improve. And hot off the press is data that it seems like patients who get some of these things, like the dysgeusia, the taste changes, and the peeling of the hands and feet, actually are more likely to be responding and have higher response rate, more durable responses. The cevostamab, which is the only one targeting this, has, again, all of these have the CRS rates of 70 to 80%, primarily the low grade, not the severe ones, modest infections, modest neutropenia. And so I think one of the questions that's being asked is, if CRS is so common in 80% of patients, can you give a treatment to prevent CRS? Keep in mind that all the bispecifics are being given with preventative steroids with the first few doses, and they're giving what's called step-up doses. So you don't give the full dose all at once, you kind of work your way up. And in spite of that, we're seeing the CRS. So there was a study looking at giving tocilizumab, which is a way to treat CRS. And you can see in the green on the right, that did reduce the rate of CRS from 80% to 36%, compared to those who did not get that in this randomization, 90%. So high-grade CRS did not seem to differ, but that's one strategy we may be able to use to lower the CRS rate, but again, still investigational. And then I also put in the thing that in the bottom there, that the DARA has also been combined with the talquetamab, and so has teclistamab. And look at the progression-free survival here for off-the-shelf products, 19 to 20 months, which is incredible. And these don't need to necessarily be given at academic centers like CAR-Ts. So I think a lot of great options for off-the-shelf. Next slide. And this just shows you one of the questions that Rafat also brought up is, do we need to treat forever? And so cevostamab is the one bispecific that we have data to stop therapy after 12 months. And you can see in these patients who stop therapy, the majority of these, indicated by the black arrows, remain in remission 1 year, and even some are approached even 2 years off therapy. So this is a whole new era of myeloma that maybe we don't need to do therapy on everybody continuously. And so that's a really exciting option that we're going to need to look at more closely across all the bispecific. Next slide. I think we can talk about this in discussion section if questions come up. So I'll go to the next slide. Let's move to CAR-Ts. So what's the difference? Well, bispecifics, those double-sided tape basically traffic your existing T cells to the cancer, and the T cells wake up and kill the myeloma. Here, we take the patient's T cells out, similar to stem cell collection, but you don't need any shots that cause bone pain. You collect the blood and collect the T cells out, and then the T cells are sent to the lab, genetically modified, and then expanded to grow into millions of cells and then put back into the patient intravenously. And then these cells know where to go. Next slide. So the CAR-Ts have different components. They have the external, meaning what sits outside of the membrane, and that's what's bind to the myeloma. And then the internal part kind of supercharges the T cell and makes it come alive. And so there's a lot of work on tweaking all of those components. Next slide. Once the CAR-T binds to the tumor, and you can see that the CAR-T is on the left and has that Y-shaped structure in the middle of the cell that's now recognizing the tumor. And so, for example, let's say it's a BCMA CAR-T. Once the CAR-T recognizes the tumor, it releases those chemicals again and causes the death of the target cell. And then so kind of, it's almost like playing paintball and putting paint on the tumor. And then now we have the snipers going after that in a very elegant way. Next slide. So what are the two CAR-Ts that are currently available? Ide-cel from a so-called KARMA study, and cilta-cel from Carditude. These are, you might have heard of Abecma and Carvykti. Those are the two brand names of these two products. Both had about 100 patients, both targeting BCMA in 6 lines of therapy, and patients had high-risk cytogenetics in about a quarter to third of patients. They even had extramedullary disease, which is myeloma outside of the bone. And then almost all these patients had had triple-class refractory disease. And what you see is a response rate of 81 and 98%. I can't remember any other study that in phase 1 or in these early settings was giving a 98% response rate. And the remission duration or progression-free survival, as I mentioned, was 12.2 and 34.9 months. That's almost 3 years. And the bulk of that is off all therapy, which is amazing. Next slide. Oh, if you could go back one. So what are the other things that we're tweaking about these CARs? Well, one of the challenges of CARs is there's not enough. there's manufacturing issues. So there's academic centers that are making their own CARs. There's alternative manufacturing. Currently, the CAR Ts are made using viruses to put the supercharged T cell receptor into the T cells. Then there's the two that we have approved are binding to, they're actually derived from mouse or llama, and now we have some totally human products. There's also what's called an allo CAR, which is not patient-derived. You're taking a donor T cell from a healthy patient or healthy individual and then modifying that to give to all patients. So it's ready to go and not patient-specific. And there's also CARs targeting GPRC5D. So you can see a lot of excitement and new strategies being pursued. Next slide. So one of the questions that's coming up is that when we have all of these products, is there a right way to do this? And one preliminary data that we have is that if you give BCMA therapy prior to cilta-cel, and that I showed you, so Carvykti, that remission of 3 years. If you give a BCMA-directed therapy prior to that, that 3-year or so remission can drop to as low as 6 months. So I think we now know that we really need to be thoughtful about sequencing these. And if in my practice, if I'm taking somebody to a CAR T with BCMA, I'm going to avoid, if at all possible, doing any other BCMA-directed therapy because you're putting all your eggs in this one basket, collecting those T cells, manufacturing and giving, and you don't want to do anything to compromise that. And then we know that if you give bispecifics, you can also lose BCMA expression, and that may be one of the reasons why CAR Ts may not work as well. If you give bispecifics till they stop working, it can affect the T cell health. So we call it T cell fatigue, if you will. And so you don't want to collect T cells when they're not in their prime condition. And then, of course, we now have other non-BCMA-directed therapies. So just something to keep in mind, if you're thinking about a BCMA-directed therapy, make sure that you talk to the center that's doing it early so that you're able to plan out your sequence. Next slide. And so I alluded to this, and we talked about how those are the studies that initially led to the accelerated approval, but to really get these therapies to move up earlier in less heavily treated patients, we need to do the randomized studies to show how do the efficacy and safety compare to existing therapies, right? So that's what we call the phase 3 studies, compare new therapies to existing therapies. And so I'm showing you on this graph some comparisons. And the first three are using pomalidomide-based regimens, but the middle two, KarMMa-3 and CARTITUDE-4, are taking these CAR Ts and comparing them to conventional therapies. And then on the two on the right, compare the CD38 like DARA or ISA with carfilzomib index to the doublet. Next. And what you can see here is the remission durations. And one of the things we're always taught in medical school is not to compare these study numbers directly. These are the progression-free survival. And the reason for that is you can see, for example, KarMMa-3, the control arm, which is not getting CAR T, has a PFS of only 4.4 months, whereas CARTITUDE-4, which is the cilta-cel's control arm, has 12-month survival. So clearly, the patient populations are different because the CARTITUDE-4's patients had an extra 8-month survival. So how do we then make some reasonable comparative statements? Next. At the very top, you can see what's the value add? How much improvement do you have over the control arm? And what you can see is both CAR Ts are demonstrating quite favorable results. Ide-cel showing a 50% improvement over the control arm, and cilta-cel 75%, which is really amongst the best that we have here on this slide. So we think in the myeloma world that these studies will likely lead to approval by insurance companies and, well, first to health authorities such as the FDA, and therefore once approved, payers will likely have to pay for these in less heavily treated patients. And these were 1 to 3 lines of therapy. And so that will be very exciting for having access. Although I would still caution that we need more slots. Just because we have approval, if you don't have enough manufacturing capacity, it's still a problem. Next. And as I told you, one of the other reasons to do a phase 3 study is not just the efficacy, but the safety. So what did CARTITUDE-4 tell us about cilta-cel versus standard of care? Well, if you look at infections, they look relatively comparable, 27 versus 25. Cytopenias, slightly more, 94% versus 86%. Of course, CRS is unique to cilta-cel, 76%, but primarily low grade. There were no, really very few high grade CRS. ICANS, which is a neurologic complication, was quite uncommon, 5%. And one of the other unique things about cilta-cel Carvykti is this concern for movement, neurocognitive disorder. So I would just tell all patients going through CAR T, if after CAR T you have any neurologic symptoms such as slowing, gait problems, difficulty writing, cognitive, and the caregivers may be the ones that notice this, somebody's just not as alert and sprightly as they used to be, those should be evaluated because we're still learning about these neurologic complications, but it seems like this is less than it was in the more heavily treated patients. Next slide. Just a brief word that these T-cell redirections are super exciting, very active, but they require a lot of training. I can tell you in the last 3 years, I've gotten more phone calls at 2 a.m., 3 a.m. than I have had in my entire 15 years prior to that. CRS does not happen at convenient times, and you need to make sure that the nurses who are monitoring the patients are trained, pharmacists are trained, ER doctors, neurologists, and so this is just a slide that it takes a village, and caregivers also need to be involved. And to do that, there's programs called Reins, which is the FDA has required that CAR Ts in particular be done at these academic centers that also do transplants. Bispecifics don't have to be done there, but the providers who give these bispecifics need to go through these REMS programs to make sure that everybody's up to speed. Next. I'll just go to the next slide and say, we can, in the interest of time, can keep going.
Yeah, that'll be good. Yep.
Yeah. This is, what if we had to compare the two? And I think this is a big question that patients have. Everybody wants a CAR T, but it's hard to get. It's that Rolls-Royce Phantom. And yes, you have a great treatment-free interval of up to 3 years, but there's a lot of patient selection, and not everybody can wait. If their disease is exploding, you don't have the ability to wait for a CAR T slot and manufacturing and all of that. And so the bispecifics are ready to go, and probably will help more patients globally than CAR Ts because of their off-the-shelf, like the Corolla. And next slide. And I'll just put this up there, but I think we can talk about it verbally. It's just how to kind of integrate all of this. But briefly, if you can get a bispecific or CAR T on a clinical trial, do so, because you may not have to wait for 4 lines of therapy. If you can get to cilta-cel, great. If not, the bispecifics are great. And then we're going to have to eventually use all of these. And I think sequencing is an unmet need. So I'll stop there, and then I think turn it over back to Dr. Durie. Thank you for your attention.
Okay, well, thank you so much, Dr. Chari, for that really comprehensive look at the exciting data with bispecifics, CAR T, and related therapies, with important cautions about toxicities, availability, all those kinds of things. So it's a balanced decision-making process for doctors and patients right now. It's not it's complex to work through all of these issues for sure. So I think that we don't have a lot of time, but I don't know, Becky, if you want to pick out 1 or 2 questions that you think are particularly pertinent.
Absolutely. I think, Dr. Chari, number 72 is a very interesting question.
Number 72, are there assays currently under development to test patients' bone marrow or blood to determine which surface antigen is most prominent for that particular patient, and thus choose the best CAR T or bispecific? Yeah. So that's a good question.
Yeah, it really is that excellent. Right now, the good news is that the patients you can see in these studies that are getting with 60 to 100% response rate practically are not selected. So that's all comers, and that's important because we don't want to have antigens that are really rarely expressed. Each of those targets is very different. BCMA does have floating around BCMA, what we call soluble BCMA, in addition to surface BCMA, so it's complicated. But right now, the testing for these is still in its infancy. But I think that will be important when we talk about sequencing, because we may want to make sure that as we're going from one to another, that we're picking the right thing. And I would say partnering that with T-cell testing, right? Because you need to look at not only the tumor cell, but you need to use the immune system's health to make really thoughtful decisions about what therapy to do at what time.
Yeah. Okay. Becky, I see that you picked number 74. Is that correct?
Yes, please.
So number 74 is trying to understand increased infection due to the fact that we're literally locking the T cells into their myeloma fight and not allowing them to circulate and fight infection. Is that a reasonable biology?
I think our current interpretation is particularly for the BCMA. Yeah, BCMA kills the myeloma, but it also kills normal plasma cells and some of the other B cells. And as a result, patients are unable to make antibodies to prevent bacterial infections and respond to vaccines. So right now, the BCMA, we're not seeming to be able to truly separate out killing the good from the bad. But the good news is we can give the IVIG to help.
Yeah. So actually, an important part of this question is that actually the infection is related to the low IVIG, which you can replace, rather than necessarily the T cells being diverted. Are you with me?
Yeah, exactly.
Yeah. Then I can see some selected by, I guess, Wendy. This is a crazy question. Given the better outcomes with Carvykti versus Abecma, why would the doctor recommend Abecma? Oh my gosh, we don't want that question. No.
But did anybody say that? I mean, there's no
I don't know.
Come on. You cannot say one is better than the other without a randomized trial.
Right. We don't have a randomized trial. Yes. And then how to make sure the emergency rooms. I think, Ajai, you were talking about how it's important to have emergency rooms, to have the floor nurses, to have the pharmacy, everyone prepared to deal with CAR T and bispecific therapies. People needs to be familiar with CRS, with ICANS, all these kind of things. It's a team effort for sure, right?
Some hospitals do give patients a little bracelet, especially in the CRS period, so that they're easily identifiable and escalated. But I think if I were a patient or caregiver, I would just tell if you're going to the emergency room, well, first thing is always call your provider and find out overnight or emergency, what's the best way to reach somebody. Everybody usually has a person on call. And then if you do end up going to the emergency room, make sure you tell them you're on a novel therapy. And patients are given often wallet cards as well, so you can show them that. But those are important things to just help convey, to educate the community, and as we'll all learn, hopefully very quickly together.
Right. We all use kind of different tricks to help our patients, who to call or where to go, or things like that. But it is very, very important to be aware of what those tricks are for your treatment. Yeah. I'm just looking here if there's anything else we can touch on. The CRS, this is something new. We didn't really see that with autologous stem cell transplant. So it is something much more frequent with the CAR T and the bispecific. So it is something new that we've been learning to cope with and to manage, as we've been discussing. Let's see. Getting PET scans every year. It is definitely good to get serial PET scans if you can. It can pick up disease that you would not otherwise pick up. The problem with that is access and reimbursement, but it's good to do it if it is feasible. Let me see.
Maybe number 7 is a good general question to answer.
Well, what is an IMiD? We can tell you that. An IMiD is one of these immune modulator drugs. And so this is an interesting thing. So it technically is an immune therapy, an IMiD. So that the thalidomide, Revlimid, and pomalidomide, these are IMiDs. And so they are immune therapies, but we class them in this class of immune modulators, IMiDs. And so it refers to those three drugs versus the new immune therapies. And then those are in two categories as well. We have just the straightforward antibodies, which are daratumumab and isatuximab. And then we have the bispecifics, which are the combined antibodies. So there are some different categories, but IMiDs is one category of what we used to call novel therapies. Okay, I think that there are some others that we haven't touched on, but I think we've reached the magic hour of 30 minutes past the hour. And if we can move forward, I would like to obviously thank the speakers for wonderful presentations. Thanks to you all for joining this webinar and for your excellent questions, which have really brought to light some of the important issues that we should all be aware of. Thanks to you. A replay of this program will be made available on our website, and you can take a look at that. As we said before, you can follow up with our info line and by email with additional questions that you feel would be good to get answered. So thanks to everyone, and I would wish everyone a very good evening. Thanks to you all.
Thank you. Thanks.